السلام عليكم.
Walaikum Assalam.
Okay, guys. Inshallah, we'll start X-ray interpretation. They will give you in the exam the most common. Is it mandatory to find X-ray interpretation in the exam? No, not common. Don't worry. But anyway, it's a very easy, very short station, very interesting, and um, I'm sure we are using every day in the practice, but we are not using for teaching in practice. That's why. So the first station will be cervical X-ray, lateral. Okay. Abbas, please, if anyone
Yes, sir.
interested to practice, you can raise your hand.
Yes, sir. Yes, sir.
Okay. I'm not sure if your signal is good or not.
Sir, actually, light gone, sir. Electricity problems. Now it is clear, sir.
Okay. So the pie chart now is teaching. You will teach what? Lateral cervical spine X-ray interpretation. Okay.
Yes, sir.
Okay. So here's the task, how to interpret. Okay. So I will give you the general approach, okay?
Yes, sir.
Okay. So here you will go inside the room. Maybe you will find only junior doctor or junior nurse and X-ray. Maybe no patient. Okay?
Yes, sir. Yes.
So what is the general approach? This is the checklist. So
Yes,
introduce
sir.
yourself to the junior doctor, inquire from junior doctor about previous experience and knowledge, ask them about everything specific. So the general approach of teaching sets and agrees learning objectives, ask for history mechanism of injury. So maybe the X-ray traumatic or non-traumatic. How, for example, chest X-ray. Chest X-ray, maybe the patient has trauma, maybe medical disease, right?
Yes, sir.
X-ray, most likely trauma. Okay.
Yes, sir.
I'm talking about cervical, most likely trauma. But
Yes.
chest X-ray, it could be traumatic or non-traumatic. So anyway, you can check the history or the mechanism of injury if injury. If the patient has, for example, pneumonia, you will ask about history, not mechanism of injury, because no injury, right?
Yes, sir.
Okay. Check patient require no immediate treatment, so you will ask, is the patient is safe now? Can a doctor care about the patient? Like that. Easy?
Yes, sir.
Okay. Explain need to check patient name and the time of X-ray, so patient details. Then A, B, C, D, E. A, B, C, D, E. A for adequacy, alignment, accuracy also. So accuracy, it means the patient name and the time of X-ray. It's called the accuracy, A. What does it mean,
Yes, sir.
accuracy? So details. Adequacy, alignment, and B, bone. It means the vertebral body. And C, cartilage. It means joint space. D, the dense, and E, soft tissue. Okay, it means anything else. Okay, so correctly interpret lateral view as adequate and normal. Check if junior doctor has any question in the end. Agrees plan, it means you will provide website videos. Answer question if he ask you any question, and so on. Okay, so the general approach as usual. Introduction. Good morning. I'm Dr. Blah blah blah, ED registrar. May I know your name and level? Smile. Nice to meet you. I believe you have something to discuss with me regarding what?
X-rays, lateral view.
Lateral cervical X-ray interpretation should be clear.
Yes,
Okay?
sir. Lateral cervical. Yes.
So if chest X-ray, you will say, I believe you have something to discuss with me regarding chest X-ray interpretation. Don't say chest X-ray only. No, interpretation. Don't say lateral cervical X-ray only. No, interpretation. Clear?
Yes, sir.
Okay, so you have two open questions. How much do you know so far about this topic? Then stop. Anything specific you want to know? Then I will set learning objectives for you. Today I will teach you the patient and film details, then ABCDE approach, and then check additional views. Easy? How many learning
Yes.
objectives?
Sir, 4, I think, sir. 4.
Three.
7. 3. Sir.
Patient and film details. You can see the slide, doctor?
Yes, sir. Yes, right.
Okay, so do you find the N4 here? In the number 4?
No, no, sir.
Okay, so patient and film details, ABCDE system or ABCDE approach, then check additional views. Easy?
Yes, sir.
Then you will talk about patient and film details. It means confirm patient, name, age, ID on the X-ray, then
Yes, sir.
date and the time, then type of X-ray, if this is cervical or chest X-ray or pelvis or ankle or whatever. So our task today is cervical, lateral cervical X-ray. And check the view. Is it AB or BA or lateral? Clear now? We finished now the first learning objectives. We will jump to ABCDE. What does it mean, A? Adequacy and alignment. What does it mean, adequacy?
Yes.
It
Adequacy, sir.
means you will see up and down, up and down.
Down.
So adequacy, you will see skull base and C1 junction, okay? Skull base and C1 junction. And down,
Mm-hmm.
what does it mean down? C7 T1 junction, clear?
Yes, sir.
C7 T1 junction. What else? You will find back soft tissue and anterior soft tissue. It means this X-ray is adequate. Easy?
Yes, sir.
Any X-ray like that, you will see the top, the base, the lateral borders. It means adequate. Like you are taking picture for yourself, for your face. If you find no hair, is it adequate?
Mm. No, sir.
If no chin, adequate?
No, sir.
If no ear, adequate?
No, sir.
No. So you should find the ears lateral. You should find your hair clear. You should find your chin clear. Easy?
Yes, sir.
Same. So the adequacy, it means skull base C1 up and it C7 T1 junction down. Easy. Soft
Yes.
tissues on the lateral sides. Okay.
Yes.
Then alignment. How many line? 4.
Yes,
How
sir.
many lines?
4.
Anterior. So this one, anterior vertebral line, because this in front of the vertebra, right?
Yes, sir.
And this posterior vertebral line. It means in the
Yes.
back of the vertebra. And this spinolaminal line, okay?
Yes.
And this spinous process line. So
Yes.
you have 4 lines. Easy?
Yes, sir.
Okay. So you have alignment, 4 lines. You should mention them. Clear now?
Yes. Yes, sir.
Okay. Then you should talk about the normal and the abnormal. It means, for example, I will go back again. Patient and film details, it's called accuracy. Patient and film details are called what?
Uh,
Accuracy.
Accuracy. Okay.
yes.
If you find patient name, age, ID, date, time, type of X-ray, view, then it's accurate. Clear, guys?
Yes. Yes, sir.
So this X-ray, for example, do you have any name here?
No, sir.
No. So not accurate. Do you have
Yes.
a date? Do you have the name of X-ray? They shouldn't put here lateral cervical X-ray. They should put
Yes.
lateral view. Okay. They should put the name of the patient. They should put the time, the date. If you find this information, it's called accurate. If not there, it means not
Not accurate.
accurate. So I want you to mention the normal and the abnormal. Easy?
Yes, sir.
Okay, then A, B, C, D, E. You will check A. So number one, A, accuracy. Number two, A, adequacy. Number three, A, alignment. So you have A, A, A. A, accuracy for patient and film details. A, adequacy in A, B, C, D, E. A, alignment in A, B, C, D. Okay, so adequacy from skull base, C1 up, clear. C7,
Yes.
T1 down, clear. And the soft tissue on both sides should be clear. If any of them missed, what does it mean?
Abnormality.
What does it mean, not abnormality, doctor? We are talking about which point?
Sir, adequacy, sir.
Adequacy. So it's not
Adequate.
adequate.
Yes, sir. It's not adequate.
Concentrate with me, doctor, please.
Yes.
Okay. So if we are talking about accuracy, if anything missed, it means it's not
Adequate.
accurate.
Accurate.
We are talking about
Adequate.
accuracy. Accuracy.
Yes.
Okay. Accuracy. So number one, accuracy. If anything missed, it means it's not
Accurate.
accurate. Then we will jump to the next point, adequacy. If anything missed, it means it's not
Adequate.
adequate. If in alignment, it means lines. Okay,
Yes.
lines. So should be smooth like that. Smooth, smooth, smooth. If you find any disruption, it means it's not
No,
aligned
there is no aligned. Yes.
or problem in alignment. Okay. Then the next point, B, bone. B, bone. So each
Yes.
vertebral body. You will check for what each vertebral body. The height, the height here, height here, height here. So height in front, height in the center, height in the back. Easy?
Yes, sir.
And the quadrangle shape. So shape normal, shape normal, shape normal, shape normal, shape normal. And also the height. Height here, three sides. So in front, back, and in the center. Easy?
Yes, sir.
Okay. Then cartilage, joint space. You will check the distance between each vertebra. The size should be equal. So the disk space, equal disk space, equal disk space, equal disk space, and so on. So you will check the disk space size and the widening. Easy?
Yes, sir.
Then the dense odontoid process. You will check the dense, this one. Any disruption, it means dense fracture. So you have dense in C1 or C2, guys?
C2, sir.
C2, excellent. So the C2, you have top here, dense, inside the C1. C1 is ring, and the C2 has dense. This dense inside the ring. Clear? So any
Yes.
disruption in this area, it means fracture of dense. Clear?
Yes.
Okay. Then extra. What does it mean extra? Prevertebral soft tissue swelling. It means you should check the soft tissue here and the soft tissue here. Any problem, like any radiolucent color, any opacity color, and you will check the size also. So the normal size, you can check at C2 and C6. At C2 and C6.
6.
At C2, this area, some sources say C3, same, no problem, because C2 and C3 almost the same, okay? So less than 7 mm. If more than that, it means fracture. Clear?
Yes, sir.
Or injury. Okay. The next one at C6 here. Some sources say C7, almost the same, no problem. So should be less than 22 mm. It means 2 centimeter. Okay. If more than
Yes.
that, it means a fracture. Clear, doctor?
Yes, sir.
Okay. So now we finished this one. Then check additional views. Additional views. Like what? We have three views. We have three views. Okay. So the actor will give you lateral view. So you have AB view or BA view. You have odontoid open mouth big view. You have also CT scan. Okay. So we
Yes.
will talk about them in details later. Easy. The station finished.
Yes, sir.
Clear now?
Yes, sir.
Okay. I will give more information. I will give more information. So the introduction first, as we mentioned, and then you will talk about adequacy first after patient detail and film. Okay. So we mentioned adequacy. It means the top. You should see the skull to top of T1 should be visible. All seven vertebrae C1 to C7 should be visualized. C7 down T1 junction should be seen. So you should see all the lens from skull base to T1. Clear, doctor?
Yes, sir.
So what if you find any of them missed? You can do a swimmer's view or you can do CT scan. Clear, doctor?
Yes, sir.
So if not visible, you can mention that. No need to wait for the actor to ask you. So you can say, if not visible, C71, you can do swimmer's view or you can do CT scan. Okay. Then the next point, alignment. We talk about alignment already. Okay. Should be smooth, continuous curves, should be normal. Any step or break deviation suggests instability or injury. If you find any disruption in any of these lines, it means instability or injury. Okay. Then vertebral bodies or bones, you will check what the height. We said
Yes,
the
sir.
height, front, back, and the center also. The shape should be quadrangle, rectangles. Okay.
Yes.
Okay. Or quadrangle, no problem. Then cortical margins. Okay. So you will check the cortex. Cortex here, cortex here, cortex here, cortex here. Should be shining white. Okay.
Yes, sir.
Okay. You will look for any problem. Any problem like what? Compression fracture, teardrop fracture, burst fracture. Easy.
Yes, sir.
So compression fracture, it means loss of vertebral body height. So the height will be short in the center. Clear?
Yes, sir.
In the center. So the height in the back, normal. The height in the front, normal. But the height in the center, short. It means this is compression fracture. Easy?
Yes, sir.
Teardrop fracture. It means avulsion of the anterior and the inferior part of the vertebral body. Easy? So if
Yes, sir.
this part of broken, it means teardrop fracture. Then burst fracture, what does it mean? Loss of both anterior and posterior wall integrity. Okay, so we finished now the B vertebral bodies. Again, this is normal. So the height here normal, height here normal, height here normal. If you find the height is short in the front, it's called wedge compression. So the height in the back normal,
Yes.
but the height in the center and the height in the front very short. It means wedge compression, means the anterior part. Crush compression, it means the center short, easy.
Yes, sir.
And burst compression, so here fracture and shortening in the center of the vertebra. So loss of both anterior posterior height, cortical break with bone fragments. Okay.
Yes,
D, disk. Disk space. So we have C, disk space. It means cartilage. Okay. So the
yes,
distance between vertebral bodies, the distance between vertebral bodies should be equal. Here, for example, widening. Can you see the yellow part?
yes, sir.
It means something wrong with disk. Okay. So one disk space appears wider than adjacent levels. This is normal, or even um, less than other disk spaces. So whatever widening or shortening, it means something wrong with the disk space. Okay. So
Yes,
normally disk space disk spaces are uniform, equal, consistent anterior and posterior disk heights. Okay. Okay. So this means ligamentous injury and instability. Okay.
yes,
Soft tissue, as we mentioned, in front of C2 or C6. Okay.
yes, sir.
We mentioned here less than 7 mm, less than 22 mm. Okay. So they can ask you in the exam, what if the X-ray is normal? What if the X-ray is normal, but the patient has symptoms or signs? This is called discordant. It means not matching. Clear?
Yes, sir.
So if the X-ray is matching, this is called concordant. No need to confuse yourself. So the normal X-ray and no midline tenderness, normal neuro, low risk mechanism, this is reassuring. If abnormal
Okay.
X-ray and you find midline tenderness, this is expected. So this is normal also. Okay.
Yes, sir.
So if abnormal X-ray but no midline tenderness, you should reassess and send your review. If normal
Yes,
X-ray and the midline tenderness or neurodeficit and the high risk mechanism, you will do CT scan. Clear?
yes, sir.
Okay. So you should correlate with midline tenderness, with neurology, with mechanism of injury, with Canadian spine rule. Easy?
Yes,
Okay. They will give you any they will give you any X-ray and you can comment. So for example, they will ask you, what is this line? What is this line? What is this line? What is this line? And so on. Here, this odontoid big C2, C7, T1, clear? So
yes.
this is adequate or inadequate?
Sir, this is seems to be inadequate, sir. The alignment is not there.
Adequate.
Adequate.
Adequate, it means you can see the four borders of the X-ray.
Yes, sir.
You can see the skull base and C1. You can see the C7 and T1. So this is adequate. You can see the soft tissue here, soft tissue here. So this is adequate. Clear, doctor?
Yes, sir.
Regarding the line smooth, yes, smooth. Okay. The line is smooth. Yes. So here it's good alignment also. Here, what is this fracture?
So this is a which fracture, sir?
Teardrop.
Teardrop fracture. Teardrop
Teardrop.
fracture.
Tear, tear.
Teardrop fracture. Okay. They can ask you, what is this line? What is this line? What is this line? Okay. What is this view?
Swimmer.
Odontoid.
Open. Open.
Odontoid or OP?
So,
Odontoid view.
OP.
okay, odontoid, big view, mouse view. So here, uh, the one with yellow color, this is the distance between C1 and C2. This is the dense, okay? This C2 and this C1. If you find the orange color, orange line, same alignment, it means no fracture, like here. This edge, same this edge. So no fracture. If you find no disruption, it means no fracture here also. So this normal or abnormal?
Normal, sir.
Normal. Okay. So normal C1 and C2. What is the fracture here?
Sir, this is wedge fracture.
Anterior
Compression
wedge
fracture.
compression fracture. Okay. You will
Yes.
find
Yes.
here the anterior height normal. Here short, right?
Yes, sir.
Yes.
So anterior wedge fracture. So they can give you any X-ray with normal or fracture. Here, what is the fracture here?
Sir, pedicle fracture.
Hangman fracture.
Hang. Yes.
C1 or C2?
Sir, C2, sir.
C2. So it's called hangman fracture. Clear, doctor?
Yes,
Yes,
sir.
sir.
Can you see the fracture here?
Yes, sir.
You can make zoom by 2 fingers in your phone. It's
Yes, sir.
obvious here.
Yes.
Yes.
Okay. So next one, what is this fracture?
Teardrop.
Teardrop fracture. So anterior and the inferior. Anterior and the inferior of the vertebral body. Clear?
Mhm.
Yes, sir.
Yes.
Okay. What is this fracture?
Jackson.
Odontoid fracture. So the dense fracture. Clear?
Yes, sir.
Yes, sir.
This the top of C2. Clear? So C1 is ring.
Mhm.
And C2 has dents inside this ring. So can you see the disruption here?
Yep.
Okay. So regarding the dents, can you see the dents here?
Yes, sir.
So C1 ring and the C2, this is the axis and the dents connected to C2. This dents or odontoid process inside the ring. So any fracture here, you can see like this. Easy?
Yes, sir.
Okay. So how many classes of dense fracture?
Three.
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 This type 1
Three.
in the top, this type 2 between the dense and the base, and this type 3 inside the vertebral body itself. Okay. So how to catch? You can catch from this view, yes, but difficult here. Okay. Can be missed easily. So you will do this view. So here's a fracture C1 or C2?
C1.
C1. If you find this edge not the same line with this edge, it
It's
means the
C1.
fracture C1. Easy?
Yes, sir.
It means the fracture here and here
Yep.
in the ring. That's why this part go lateral, this part to go lateral. Easy, guys?
Yes, sir.
Okay, but the dense is intact, right?
Yes.
Okay. What about this? You have
C2.
here fracture and you have here
C2.
fracture. So what
C2.
is the problem?
C2.
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 Can you see the fracture here also?
Yeah.
So this one type 1, this one
1,
type 2.
2.
Okay. So the patient has fracture here and the fracture here. Okay.
Yes.
But the edge, same line or not? I'm talking about the alignment.
Same.
Normal?
Yes. Normal.
It means no fracture in C1. Clear?
Yes, sir.
The fracture only in the
C2.
C2, the dense odontoid fracture. Clear, doctor?
Yes, sir.
Yes, sir.
Okay. So you will teach the normal. I will check if any X-ray. Okay. So you will teach the normal and they can give you any X-ray later. Okay. So you will need only this slide and this slide, doctor. Clear?
Yes, sir.
Okay. You have 30 seconds and 6 minutes.
Sir, if they
Sir,
ask about, sorry, If they ask about management, then we will just say the
Yes,
normal.
yes. If they give you any X-ray in the exam, comment. Um, no need to say, for example, adequate align and blah blah blah. You will waste the time. I mean, for
Mm,
example, if they show you um, any X-ray with fracture, for example, this one,
mm.
is this one adequate or not adequate?
Adequate.
Adequate because you can see the four borders, right?
Yes, sir.
You can see up, you can see down, you can see the soft tissues. So this is called adequate, right?
Yes, sir.
Any information about the patient,
No.
it means not
Accurate.
accurate. And the alignment, any problem in alignment?
No, sir.
No. So this
Well
line
aligned.
normal, this line normal, this line normal. If the patient has fracture, doesn't mean he has problem in alignment, right?
Right, sir.
The patient has problem in A or B or C or D.
B.
B bone in the
Bone.
cartilage, right?
Yes, sir.
So the 1, 2, 3, 4, 5. So the fifth vertebral body, different shape and the height of the anterior part. And you have here the cortex disrupted also. Can you see the line radiolucent here? Clear?
Yes, sir.
And the cortex disrupted here, anterior line. Okay?
Yes, sir.
So if you will comment on everything, you will waste the time. If you will say not accurate, uh, adequate, and normal alignment, but the problem here in the vertebral body shape and the height, you will waste the time. If you have one X-ray only, the actor is holding one X-ray only, take your time. But if
Mm.
he's holding, for example, 4 or 5 X-rays, don't waste the time. Easy?
Yes, sir.
It will be obvious in front of you, right?
Yes, sir.
Okay. Any question before we start?
No, sir. Thank you.
Okay.
Sir,
Yes.
sir, inshallah, sir, you will help with me because, sir, these few videos were not present in the past, so kindly help with this test.
Of course, I will help you. We are here to help you, Abbas.
Yes, sir, yes,
Even if you will not do well, what is the problem?
yes, sir, yes.
We are here to support you. Okay?
Thank you, sir. Thank you.
Yes. Okay. You have 30 seconds and 6 minutes. You can start.
Hello, my name is Dr. Mohammad Abbasan, and I am the ED registrar here. May I know your name and level, please? I believe, nice to meet you. I believe you have something to discuss with me regarding this X-rays. How much do you know so far about this topic? Anything specific you want to know? I will set learning objectives for you today. I will teach you patient and film details, A, B, C, D, E, adequacy, it means skull base, C1 up to C7 and T1 junction down, alignment, anterior longitudinal vertebral line, posterior longitudinal vertebral line, the spinolaminar line, and the spinous process line. We will also discuss the B for the bone, each vertebral body, and cartilage, joint space, dense odontite process, extra prevertebral soft tissue swelling, and check additional views. Did you understand? You have any question, you can ask. I will also give you details regarding the websites and videos, and I will recap for you. Okay, we will start first with the patient film and details. This is called accuracy. So we will check for the patient's name, time, date, type of X-ray, chest AP view or lateral and PA view. We will confirm the patient identity. And then we will check for the alignment, adequacy. We will check for the skull base and then from the C1 down C2, C3, C4, C5, and C7. So we will check the height of the vertebrae, and they are in C7 to T1 junction down. Then we will check the alignment. We will check the lines. One is the anterior vertebral line,
Okay,
and
so here adequacy, you mean, doctor, from skull up and the C1 junction, and
yes,
down
sir.
you said C7 and the T1 junction, and anterior border soft tissue and the posterior border soft tissue.
Yes, sir.
So the adequacy, we should see four borders.
Yes, sir.
Okay. And alignment, what do you mean by alignment, doctor?
They are the interior border, interior vertebral line, found by the interior borders of the vertebrae. The posterior vertebral line found by the posterior border of the vertebrae. These lines, and then the spinolaminal line by the laminar bodies, and the spinous processes line by the spinous processes.
Okay, so here, if the patient, regarding the patient and the film details, if I did not find the information, what does it mean?
It is not accurate, sir.
Okay, and regarding ABCDE system, if we did not find the skull base or T1 or soft tissue, we did not find. What does it mean?
So this means that there is a gap, sir, between the vertebrae, sir,
Not adequate.
not adequate.
Okay, so if we did not find T1, what to do? Which
Sir,
view we should do?
sir, we will do the sir anterior view, or we can do the CT scan.
A swimmer view, swimmer's view,
Swimmers. Yes,
swimmer's view. Okay, like
yes,
the patient is swimming.
yes, sir.
Okay, so he will take the position of a swimmer and you will take X-ray. Okay, you said
Yes.
alignment. We have four lines. Okay, so if we normally, how it looks?
As so they're
Smooth,
just like,
smooth.
yes, sir. Smooth. Yes.
Okay, and abnormal, how it looks?
So there will be misalignment, sir.
Disrupted lines.
Disrupted.
Okay,
Yes.
so what is the next point, doctor?
Sir, bone, sir. We will check the height of the bone, anterior border, and
What do you mean
posterior
by
border.
bone? Which bone?
Sir, first is the C1 and then C2, sir.
Vertebral bodies.
Vertebral bodies, yes.
Bone, it means each vertebral body.
Yes, sir.
Okay, so what do you need in each vertebral body? We will check what?
Height, sir. Height of the vertebral body.
Okay, height and the shape
Shape, yes, sir.
and the cortical corners.
Yes, sir. Corner.
Four
Yes.
corners, right?
Yes. Yes, sir.
So each vertebral body, we will check the height. Height here, anterior, posterior, and center.
Yes, sir.
And the shape should be quadrangle or rectangle. Okay?
Yes. Yes.
And four cortical corners.
Yes, sir.
Okay. So if all the same shape, same height, it means normal. So any problem in height, it means
Compression fractures.
a fracture.
Yes, sir.
Any problem in height, it means a fracture. Okay.
Fracture.
So if the height in the anterior part is short, what does it mean?
Sir, wedge-shaped anterior fractures.
Okay. And if the height in the center short.
Sir, then compression fracture centers.
Okay, if the height in the anterior and the posterior is short and fracture in the vertebral body, what does it mean?
Mm,
Burst fracture.
Burst fractures.
Okay, if the fracture in the anterior part and the inferior, avulsion,
The teardrops
teardrop.
fractures.
Okay, what is the next point, doctor?
Sir, extra
Dense.
dense, yes, sir. Odontite process,
Okay.
dense.
So normal it should be
It should be in the C1
intact.
inside,
Intact.
intact,
So
intact.
any disruption or any radiolucent color, it means fracture.
Yes, sir.
Okay, so this for C2. What is the next point?
Extra prevertebral soft tissue swellings.
How I know it's swollen?
Sir, less than 7 millimeter should be the normal, sir.
Where?
At a level of C2, sir.
Okay, and what else?
Less than 22 millimeter at C6, sir.
Where? Okay, C6.
At a,
Okay. So
yes,
if more than that, it means swollen. What does it mean, swelling?
soft tissue swellings, sir. Any infection, any
Injury.
injury, sir.
So
Yes, sir.
infection if medical disease or injury if trauma.
Yes.
Okay. And what is the next point?
Check the additional views, sir.
Like what?
Sir, like anterior view, odontite, pig view, sir, and CT scans.
Why? To check for what?
To check for the C1 and C2 fracture, sir.
Okay, excellent. And
Yes.
CT scan. CT scan for what?
Uh, Sir, if any missed fracture, it cannot be pricked in the X-ray,
So
sir.
CT scan if normal X-ray, but high mechanism of injury. Okay.
Yes, sir.
And
Yes.
if the patient has what?
Uh, missed findings. Sir, yes, sir. If they are not tallies with the symptoms of the patient, sir.
So if the
And they
patient
stop.
has normal X-ray, midline tenderness, and or neurodeficit and the high risk mechanism, you will consider CT scan and the further imaging. Easy?
Yes. Yes, sir.
Okay, so this is adequate or inadequate?
Sir, adequate, sir. Adequate.
Okay. What about alignment?
Yes, alignment is also there, sir. Same
Okay.
alignment.
And regarding accuracy?
Sir, like, it is not accurate because patient name and address is not given.
So information not there.
Yes, sir.
Also not written here, lateral X-ray, not written here, right? Not
Yes, sir.
written cervical X-ray, not the patient name, age, ID, not there, right? Date
Yes,
and
sir.
time not there, so not accurate, right?
Yes, sir.
What is this fracture?
So this is teardrop fractures.
Okay. And this normal or abnormal?
Sir, normal, sir.
Why?
Because alignment is of the C1 and C2 is there, sir.
Okay. And regarding the dents, any
Then,
disruption?
no, sir.
Okay. What is the problem here?
Sir, anterior wedge compression fracture.
Okay.
Height is lost.
Why? Why?
Because height is lost anteriorly, sir.
Okay. And what is this?
Sir, so there is, yes, sir. So this lamellar C2 fracture and main fractures.
The fracture here horizontal or vertical?
Vertical, sir, vertical.
Vertical. Okay. Is this serious?
Yes, sir, yes, sir, it is serious.
Stable or unstable?
Sir, unstable, sir.
Okay. Is this one serious or unserious?
Sir, serious, sir, anterior wedge compression.
Okay. So it will affect the spinal cord. This will affect the spinal cord also, right?
Yes, sir.
Okay. What about this one?
So this is teardrop fractures.
Okay. It can be associated with spinal cord? Yes, also.
Yes.
Okay. What is this?
So odontite fractures.
Okay. What is the problem here?
And sir, this is there is misalignment, sir. So C1, C2 fractures.
What is the problem? C1 or C2?
C1.
C2, sir.
C1.
One.
C1,
C1.
Yes.
C1.
Yes, sir.
Which one is going out?
Yes, sir.
The ring.
Ring.
The C1, right?
Yes, sir.
If you find the C2 going out, it means the fracture in C2. Clear?
Yes, sir.
So C1 is going out. It means the fracture here. It's obvious here. Okay.
Yes.
So this part going out, this part going out, lateral. Okay.
Yes, sir.
How to know it's lateral? Compare with the anterior border, with the medial border of the teeth. Clear?
Yes, sir.
So it's going towards the outer border of the teeth. Okay?
Yes. Yes, sir.
Okay. So what is the problem here?
Sir, odontite process fractures.
Yes, and the vertical fracture also in the C2 itself, right?
Yes, sir.
Okay. Okay, thank you, doctor. Okay,
Thank you. Thank you.
well done. You are doing well, but I want you to concentrate, okay?
Yes, yes.
I will give you 7 out of 10. Anyone else want to practice this station?
I can practice, sir.
I can too.
First, we will start with people who did not practice. So, Sondus, did you practice?
No, sir. Can
Okay,
I?
your turn.
Okay.
The station is clear to you now?
Yes, sir.
Okay. So you have 30 seconds and 6 minutes.
Good morning. I'm Dr. Sundar, CD Registrar. May I know your name and level, please? Nice to meet you. I believe you have something to discuss with me regarding cervical spine X-ray interpretation. How far do you know about it? Any specific thing you want to learn? I will set learning objectives for you. We will discuss patient X-ray, their details, ABCDE approach to read an X-ray, and then we will check an additional view. I will also share videos and link with you so that we can keep this learning process going on. First of all, we will start with the accuracy. We will start with the patient's information and just make sure that patient is safe and somebody is taking care of the patient. Now, talking about the X-ray. X-ray starts with the accuracy, that means patient detail, patient name, patient ID, and date, and the type of X-ray it's view. Then we will go with the adequacy. That means the X-ray is adequate. The four borders of X-ray is visible. The skull base, in this case, cervical spine X-ray. The skull base above. The C7, C6, C7, D1 junction below. And at both sides, we have these soft tissues. That means this X-ray is adequate. Next, we are coming toward alignment. Alignment means that anterior, there are four lines we need to talk about it. That is the, if we go from the last, that is called spinous process. These are the lines most posteriorly. And then there are two lines, one anterior to vertebral column. We will say this as anterior, anterior spinal line, and then anterior vertebral line, and then the posterior vertebral line, and and the line between the spinous process line and posterior vertebral line is called spinolaminar line. Our spinal cord, there is a structure that goes from here between the spinolaminar line and posterior vertebral line, and that's called a spinal cord. We next go to this. This completes our A. Are you with me till now? So in A,
So
we read,
normally like what and abnormally like what?
yes. So normally, so this is normal. The alignment is normal, that each line is on its provided space.
How I
And
know the alignment is normal?
uh,
So smooth, no disruption.
okay. So the lines are smooth. There is no disruption. There is no any change in space. So this is normal
If any
alignment.
disruption, what does it mean?
That means there is any abnormality, which
Fraction.
is any fracture. Yeah, there
Okay.
is any fracture. Next, we have completed adequacy, alignment, and accuracy. Now we will talk about bone. In this case, we have vertebral columns and vertebrae, and we will talk about C1 to C7. And in each vertebrae, it should be we see the height, shape, and then we trace the cortex. If it is normal in a wedge, in a triangular wedge shape, this is normal. And if we find any border or any shape which is not equal to other one, then that could be a fracture of that vertebrae. Over here
So
we
the
can
height
see
where? Height where, doctor?
uh, height from between each other
Anterior,
and
posterior, and the
posterior.
center of the vertebra.
Okay, so height
And the
between each
shape should be
square, r-
rectangle or quadrangle.
quadrangle. Okay, so the shape should be
And what
quadrangle.
else? Number three, cortical corners.
Okay, yes.
Four
Cortical
corners.
corners. Okay.
Okay.
So cortical corners, and we also see the spaces between them. They are
So how I know the fracture?
whenever
Give
we
me
see that.
examples, doctor. Give me examples. So, for example, what are the common fractures and how I diagnose them?
So common fractures could be wedge fracture. If we
Okay,
see
how I
that,
diagnose?
so on anterior border, you will find there the space is narrowed. There
Not the
is
space. We are in the point of vertebra now, not the space. We are
yeah,
in the
sir,
point of bone.
bone. Yeah,
Don't jump to cartilage now. So we are in the
thigh.
point of bone. So how to catch the diagnosis of anterior wedge compression fracture? So the height of anterior border of the vertebra is short.
Very short. Okay.
Okay, what else? Common fracture.
Then we can have a teardrop fracture that is also on an anterior border, lower border, and that would be
Anterior,
uh,
inferior,
anterior inferior,
corner.
and then corner, and then
We
we
have
have
four corners, right?
yes, sir,
So the anterior, inferior corner of the
right,
vertebral body, avulsion.
a Vulgin fracture. Yeah,
Okay. What
okay.
else?
And then we have the hangman fracture at C2. Over there we can find that there is a disruption between C1 and C2,
So
and
the
this
disruption in which line?
in spinolaminar line,
Posterior, posterior
posterior line.
vertebral
Oh,
line. Okay, in
okay,
C2,
oh,
right?
okay.
Okay, what else?
And in vertebral, we can also find odontoid fracture, and that can we see at by
Vertical or
odontoid
horizontal?
uh, horizontal.
Horizontal. So this one vertical, this one horizontal. Both of them in C2, right?
Yes, sir.
Hangman fracture and dense fracture. Okay, what else?
And mm,
Compression
mm,
fracture.
yeah, compression fracture that will involve the whole vertebral height of the
The center,
vertebrae,
the center.
the center. Yeah, and that's
Shortening of the center of the vertebral body. Okay. And
yes,
the next one is burst fracture.
yes, burst fracture.
It means loss of height in the anterior and the posterior height and
Hmm.
fracture of the vertebral body.
Yes, sir.
Okay, what is the next point?
See, cartilage, that means joint space, and it should be, we will trace from above till down. Each cartilage space should be equal. If we find that any space is narrow or more, that means there is any injury of the cartilage, or there
Or,
is any
or ligaments.
or
Cartilage
ligament.
or ligaments. Okay, what is the next point?
Then extra, that means soft tissue. Then we will see C2 and C7, and we should know that at C2 the space should be less than 7 centimeter, and if and from C7
millimeter.
millimeter, and C7 22 millimeter, and if it is more, that means we have any infection in our soft tissues, any abscess or anything over there. Then we come to
But in this
uh,
case, trauma. So it means
injury.
injury. So check the scenario. The scenario trauma, talk about trauma.
Hmm.
Okay,
Okay.
what else?
Then we have density.
Check
Then we
additional
have check
views.
additional views. That means we need to get other views. If C7 and T1 is not fully visible, we can have a swimmer view. And if we need to have a odontoid view to just clearly see odontoid process,
So if we
um,
have suspicion about C1 or C2 fractures, we can do odontoid
odontoid
open
view.
open mouth big view. Clear?
Okay, sir. Okay.
And when to do CT scan?
When when the patient history is suggestive of a fracture or an injury, but we are not finding it on x-ray, then we can we can have CT just to be concordant with the history.
Okay. So if Canadian spine rule is indicating imaging,
Hmm.
and if Canadian spine rule not indicating, but the X-ray is normal, and the patient is showing any suspicion of fracture. Okay.
Okay, sir.
Okay. Well done. Thank you.
Thank you.
I will give you 8 out of 10. So I try to optimize your approach. Okay.
Yes,
So
sir. Thank you.
they can show you the any fracture. So this one adequate or inadequate?
Adequate.
Accuracy?
Not.
Not accurate.
Not accurate. And what is this fracture?
Teardrop.
Okay. Which vertebral body?
C one, two, fifth.
Fifth. You should say teardrop. Fifth
C5.
vertebral body. You can
Hmm.
say I can see avulsion, anterior inferior corner, cortical corner. How many corners?
4.
Easy now how to catch the finding, how to catch the
Yes, sir.
diagnosis?
Yes, sir.
Okay,
Thank you.
welcome. And what about this view?
Odontoid view.
So
Open mouth.
open mouse, odontoid, big view.
Hmm.
Open mouse, odontoid, big view.
Okay.
So this normal or abnormal?
Normal.
Accurate or inaccurate?
Accurate.
No.
Not accurate.
Do you
Not
have
accurate.
information?
No. No. No
No.
information.
Adequate or inadequate?
Adequate.
No. Can you see the shin?
Okay.
You
Not
should
adequate.
you should see if you have picture of someone, if you did not see his
Hmm.
shin, is it normal?
No, no, sir.
No. You should see the shin. Okay. So yes, you are doing this one. So you should
Hmm.
see the soft tissue here. Can you see the soft tissue?
Yes, sir.
Soft tissue here, soft tissue here, up here, up here.
Hmm.
Okay. But anyway, the most important C1, C2. If you can see the C1, C2, you can
Hmm.
consider adequate, no problem. Easy? Okay.
Yes.
This one normal or abnormal?
Normal.
Normal. So the distance or the yellow
Is
part
not.
is
Hmm.
equal. So here equal, here equal. So center or not center? I mean the
Center.
X-ray is centralized or not?
Centers.
If you find this one not equal this one and the alignment normal, it means the patient is rotated. So rotation, it means abnormal also. Clear?
Yes. Yes, sir.
So how to know it's centralized? If this one equal this one and the alignment is normal. Easy?
Yes, sir.
Okay. Even the alignment not normal but equal, it means centralized. How? For example, I will show you This one. So the
Mm.
distance here equals the
Mm.
distance here. Did you get my
Yes.
point?
Yes, sir.
It means this patient centralized, normal.
Mm.
Okay. What is the problem here?
Sir, C1 and C2 fracture and
C2 only. The alignment normal.
mm.
The alignment normal. Okay. So the blue line, same.
Mm.
Okay.
Okay, sir.
Up and down, same. Same
Mm.
edge. Up and down, same edge. Clear?
Yes, sir.
It means C1 is normal. So the
Mm.
alignment responsible for C1. Easy?
Yes, sir.
Okay. So the fracture here in the dense, the fracture here obvious, the fracture here obvious, the fracture here obvious, in the base also. And here also, if you check here, this
Mm.
part also, there is disruption here. Okay?
Mm. Mm.
And here disruption also. Okay. So this one in C2, in the dense and in the vertebral body itself. Okay?
Yes, sir.
Okay. Okay. I will give you 8 out of 10. Thank you.
Thank
Next
you, sir.
one, Mona.
Yes, Doctor.
How are you?
Good, Alhamdulillah. Thank you.
Okay. Chest X-ray, it's common. We are doing that every day. So how to teach this? So you will follow the same approach, okay? So you will do introduction. Good morning, and blah blah blah. May I know your name and level? Nice to meet you, Smile. I believe you have something to discuss with me regarding what?
X-ray?
No, chest X-ray interpretation.
Okay.
How much do you know so far about this topic? Stop. Anything specific you want to know? Clear?
Okay.
Then I want you to pause, guys. For Abbas, Abbas is not pausing. Abbas is saying everything in one shot. I believe you have something to discuss with me. How much do you know so far? Anything specific? No. You should pause between points. So you should say, how much do you know so far about this topic? And stop. Then anything specific you want to know? Stop. Pause. Clear, doctor? Okay, I will set learning objectives for you. Today I will teach you the patient and film details, assess image quality. Mnemonic is RIBE, R-I-B-E. Assess ABCDE system. A for airway, B for breathing lungs, C for cardiac cell, D for diaphragm, and E everything else. Then check additional views. Clear?
Yes.
Patient and film details. Confirm patient name, age ID, date and time, type of X-ray, and view. If you find them, it means accurate. If any of them missed, it means
Not accurate.
not accurate. We finished this one. Number two, assess image quality. RIBE. R for what? Rotation. RIBE. R-I-B-E. R for what?
Rotation.
Rotation. You are checking is the X-ray centralized or rotated. For example, if you are taking picture for yourself, your face, you will understand you are centralized or you are looking to the right or looking to the left, right?
Mhm.
So, how to know it's rotated or centralized? Check the clavicles. So the clavicle here and the clavicle here. Clavicles equidistant from spinous process. So you will check the distance here from distance here. Easy?
Mm.
So the spinous to the clavicle. The spinous to the clavicle. Equal or not the red line?
Equal.
So centralized. Easy?
Mhm.
Then I, inspiration. How to know this X-ray taken in inspiration or expiration? At least 6 anterior ribs visible. Easy?
Mm.
So 1, 2, 3, 4, 5, 6, 7, 8. So if you find at least 6 anterior ribs visible, it means inspiration. Clear? Clear, doctor?
Yes, yes.
Okay. Projection or penetration. You can say P, projection or penetration. It means this X-ray is posterior anterior or anterior posterior. So which view? Okay. So
Okay.
the normal should be BA view.
PA.
Okay. Exposure. Thoracic vertebra. Can you see thoracic vertebra?
Yeah.
Faintly visible behind the heart.
Mm-hmm.
Okay.
Yeah.
Okay. So you should see. Okay. Then we will go for the next point. The A, airway, B, breathing lungs, C, cardiac cell, diaphragm, everything else. Easy.
Mm-hmm.
In this point, you should mention the normal structures first. So you can say this is the trachea, this is the spinous process. In the X-ray, in the exam, no need to be very dedicated. I mean, no need to put your fingers to the actor and confirm his understanding or not. Maybe he's not medical field, right?
Mm-hmm.
So just mention quickly, this is the trachea, but at least put your finger here. Easy.
Mm-hmm.
This is the trachea, spinous process. This is the aortic knob. This is the left hilum and the pulmonary artery. This is the right hilum and the pulmonary artery. This is the trachea we mentioned, and we will go down, down, down. We will see here the carina. Okay. So this is the right atrium. This is the left ventricle. We can see here the diaphragm, left diaphragm and right diaphragm, and the angles, two angles here and two angles here for diaphragm should be acute angles, clear? Or sharp angles. So what is this angle, doctor?
Ostropenic.
Costocardiac angle. Costocardiac
Costocardiac, sorry.
angles.
Mm-hmm.
And this costophrenic angle, clear?
Phrenic, yeah.
So the
Yes.
junction between the costal and the heart is called costocardiac. The
Cardiac.
junction between the costal and the phrenic,
Diaphragm.
it means costophrenic
Costophrenic.
angle. Okay, easy.
Yes.
And this is the clavicle, of course, and this is the shoulder. Okay.
Mm-hmm.
So here, accurate or inaccurate?
Not accurate.
Why?
There's no detail, patient's detail.
No patient information. Excellent. Adequate or inadequate?
Adequate.
Because you can see the four borders, right?
Mm-hmm.
Four borders up, you can see the cervical spines, and down you can see the diaphragm, right?
Mm-hmm.
And in the lateral, you can see the soft tissue. Soft tissue, easy.
Yes.
I think it's clear now in X-ray.
Yes.
Okay, and alignment. So you can see the central line. Okay, so here you will follow right. So R, what does it mean R?
Rotation.
Rotation. This one, you will check the distance between clavicle and the spinous process equal both sides. So this
Mm-hmm.
patient centralized, right?
Yes.
And I, inspiration. At
Inspiration.
least how many reps should be clear?
6.
Okay, so you can count in the exam. 1,
Mm-hmm.
2, 3, 4, 5, 6, 7, 8. So more than 6.
Mm-hmm.
So this
Mm-hmm.
inspiration. Easy.
Mm-hmm.
And what else? B.
Projection.
So this AB or BA? BA.
PA, yeah.
And E,
Is exposure.
exposure. So what does it mean, exposure?
You can see the thoracic vertebrae in the middle behind the heart.
So faintly, okay. Thoracic vertebra faintly visible behind the heart. You should say like that. Easy.
Okay.
This one clear, but this one not obviously clear. Okay.
Mm-hmm.
Clear, doctor? We finished now, right?
Yeah.
Then assess ABCDE system. A for airway. What does it mean, airway?
Trachea.
Trachea. Central or deviated? This one, central or deviated?
Central.
Okay. So here for airway, you will check trachea central or not, carina visible or not. Easy.
Yes.
For breathing, what does it mean breathing? It means
The
lungs.
lung fields. Yeah.
So lung feels clear or not? Clear, right?
Mhm.
What else? Vascular markings, like tree. Can you see the vascular markings?
Mhm. Yeah.
Normal. So if you find here reach the chest wall, these markings should reach the chest wall. If not reaching the chest wall, it means pneumothorax, right?
Yes.
Okay. Look for what? Abnormalities like what? Pneumothorax, consolidation, collapse, nodule, effusion. 1, 2, 3, 4, 5. Easy?
Mhm.
Anyway, I will show you the slide, okay?
Okay.
Circulation, it means what?
The heart.
Heart. So you will check the cardiac size. Cardiac size. Normally, the cardiothoracic ratio less than 50% on BAVU. Okay.
Mhm.
How to calculate? So you will measure the
The
heart
diameter.
size and the thorax size, and you will make the ratio should be less than 50%. Okay.
50%. Mhm.
Okay. Cardiac borders clear. So here clear or not?
Clear.
The cardiac borders up, middle, down, here the base, here the apex, mediastinum, the left and right borders. So cardiac borders clear, right?
Mhm.
Mediastinum not widened. So the mediastinum here normal. Aortic knuckle visible. Okay. Can you see? Okay.
Yeah.
Then the diaphragm, D for diaphragm. So right diaphragm should be higher than the left
Left.
diaphragm. This is normal. So if you find the right diaphragm same level or down, it means abnormal. Clear?
Mhm. Yes.
Okay. You will check the costophrenic angles and costocardiac angles. So these angles and these angles. We said it should be sharp. So
Mhm.
this one, sharp, 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 4 angles. If not sharp, it means
Fluid.
pleural effusion. Clear?
Yeah. Yes.
Okay. No free subdiaphragmatic air. So no air here, no air here. If you find the air, it means
Perforation.
perforation, whatever traumatic or non-traumatic, okay?
Mhm.
Then E for everything else. It means bones or soft tissue or anything attached to the patient. What does it mean? Tubes, nasogastric tube or ET tube or any device like implantable cardioverter or I mean basing like that. Easy? Or
Mhm.
electrodes of ECG monitor. So everything else, it means bones like ribs, any fracture, clavicles, any fracture, scapula, any fracture, spine, any fracture. So you can check the fracture here also? Yes. You can check the vertebral bodies? Yes. Easy?
Yes.
Okay. Soft tissue, check of soft tissue, any radiolucent color, it means subcutaneous emphysema. It means
Mhm.
fracture. I think it's clear now.
Mhm.
Clear, doctor?
Yes.
So to summarize, after you mention everything, you can say, so normal X-ray checklist should be trachea central, lung fields clear, normal vascular markings, no pneumothorax, heart size normal, diaphragm normal, costophrenic angles sharp, no acute bony abnormality. Easy? So
Okay.
8 points to say this X-ray is normal. Again, I will show you the slide, okay?
Mhm.
Okay. So for airway, we mentioned already. So you can comment about airway if trachea is deviated, what does it mean?
It's a pneumothorax.
So if the trachea deviated away from the lung, it means a tension pneumothorax
It's a pneumothorax, yeah.
or massive hemothorax. And if mass effect, like for example tumor, it will displace the trachea away from the lesion. Okay. We will go for breathing. So breathing, we said normal, clear lung fields. So if you find consolidation, what does it mean, consolidation? It means
Pneumonia.
opacity. I'm talking about the
Mhm.
finding first, not the diagnosis.
Okay.
So if you find the opacity, increased opacity, and this opacity obscuring, it means covering the bronchovascular markings, it means consolidation. It could be pneumonia. Easy?
Mhm.
If you find the blunting of the costophrenic angle, so it means pleural effusion.
Pleural effusion.
If you find visible visceral line or pleural line and the absence of vascular marking, it means an pneumothorax. If you find bilateral prehilar opacities, it means edema.
Malaria.
Easy? Okay.
Yes.
So I mean, when you reach each point, mention the normal and the abnormal. Clear? Okay. Then you will go for C, cardiac cell height. So we mentioned already the normal size. So the cardiothoracic ratio, what does it mean?
The heart to the thorax, less than 50%.
Yes, on BA film. Okay.
Mhm.
So if less than 50%, the heart
Normal.
size divided by the thoracic width should be less than 50%. This is normal. Okay. So cardiomegaly, it means more than 50%. Aortic pathology, it means wide mediastinum. So you will comment on these abnormalities in each point. So abnormalities of the lung fields in lung fields, abnormalities of the heart or aorta in C, cardiac circulation. Did you get my point?
Do you have to measure the mediastinum or not? For the
Yes,
widen?
yes. Because what does it mean C? Circulation. What does it
Mhm.
mean B? Breathing, lung. So here you will comment on the normal lung fields and the abnormal lung fields. Easy?
Mhm.
C, you will comment on circulation. It means heart and aorta, right?
Mhm.
Heart is relevant to circulation, aorta is relevant to circulation. I wish it's
Yeah.
clear. So, heart, how to know it's a cardiomegaly? We mentioned already.
More than
How to know it's
50%.
aortic rupture, whatever traumatic or non-traumatic, wide mediastinum.
Widen
If
mediastinum.
non-traumatic, it means aortic dissection or rupture. If traumatic, it means aortic injury. Easy? Okay. Then we will go for the diaphragm. We mentioned already the upper, the right is above the left. Okay. So you will comment here on pleural effusion and the pneumomediastinum because this is relevant to the diaphragm. Clear? Pneumoperitoneum, sorry, not pneumomediastinum. Pneumoperitoneum. Okay. So pleural effusion, this is relevant to the angles. If you find the angles blunt, it means pleural effusion. If you find air under diaphragm, it means pneumoperitoneum. Clear?
Mhm.
Okay, so you will mention the normal and the abnormal. Okay, after that, everything else. Everything else like what? Rib fractures. You will check the bones and you will check the clavicle. You will check the spines. You will check the vertebral bodies. Clear, doctor?
Yeah.
Okay. And ET tube position. The tube is connected or not, if connected central or not, in the above the carina or inside the right main bronchus. Okay.
Mhm.
The NG tube is in the stomach or not. The NG tube in the esophagus or in the stomach. Central line placement, maybe the patient has already central line I'm talking about carotid, for example, line or internal jugular line. What else? You will check ICD connected or not. Did you get my point?
Mhm.
Okay. So now we finished everything. Maybe in the exams, they will show you the abnormal X-ray. So, for example, pneumothorax, you will say, I can see visible pleural
Loss
light,
of, yeah,
lung
and
edge
loss of vascular
retracted.
marking.
Yes, lung edge retracted, no peripheral lung markings. The trachea may be deviated, obvious. The mediastinum shift also. So this is pneumothorax where in the right side, for example. Clear? This one,
It's probably edema.
pulmonary edema. So you can say, I can see bilateral prehilar opacities. It means opacities here, 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 here. So bilateral, easy. Vascular congestion. So pleural effusion because blunting, you cannot see the edges not sharp. Okay. And the cardiomegaly, it means the heart size more than 50%. Okay. How to know it's a cardiogenic or non-cardiogenic? If you find these findings without cardiomegaly, non-cardiogenic. If you find the cardiomegaly, it means a cardiogenic. Easy
Mm,
until proven
okay.
otherwise, until you do echocardiography to confirm. What is the problem here?
Consolidation.
Opacity in one part. So if you find the opacity diffuse bilateral, it means edema. If you find the opacity in one part, this is called consolidation. So it's called pneumonia, infection. Okay? And here, massive
Effusion.
pleural effusion,
Pleural
because
effusion.
it's not about blunting. No, the part of the lung is absent. Clear?
Yeah.
It means pleural effusion, massive. Okay. So I think the station is clear now.
Okay.
You have 30 seconds and 60 minutes.
Okay, I'm ready. Okay. Right. Good morning. My name is Dr. Muna. I'm one ED registrar. May I know your name and level, please? Nice to meet you. I believe you have something to learn about from me about X-ray, chest X-ray interpretation. Is that correct? And may I know how far so far you know about this topic? Is there anything specific you want to learn about this topic? That's okay. Today, I will set learning objective for us. Okay. So I will teach you about patients' film details, assess image quality. The mnemonic is RIPE. And then we will learn about assess ABCDE system, which are the airway, breathing, lungs, cardiac silhouette, diaphragm, everything else. And we also learn about check additional views. Do you understand so far? Do you have any question? I will provide websites and information at the end of the teaching, and I will also recap the learning objective today. Thank you. So we will start with the patient's film details. First, a chest X-ray must have a patient's detail name, age, and ID. At the same time, it has to have a date and time of the X-ray taken. And then we can also check the type of X-ray of the patient, whether it's a chest X-ray, whether it's pelvis or ankle, and then the view of the image, whether it's AP, PA, or lateral view. Okay, so for the patients, and then we go to the assess the
So
quality.
if this information are present, what does it mean? If absent, what does it mean?
Okay, so if you have all this information, it means the image is accurate because it belongs to the patients and taken at the date and time
And
of the
if
X-ray taken.
absent,
So it's not accurate.
okay, next point.
Okay, next point is to assess the image quality. So the mnemonic is RIPE. R is for the rotation. So for the rotation, we check the patient's clavicle. So the clavicle has to be same equal distance from the midline, which is the spinothoracic. And then we measure on the right and left of the clavicle. It must have the same length of both clavicle. Next, we go to
So
the...
this one centralized or rotated?
So this is centralized because
Okay.
it has
Next
same
point.
distance. The next point is the inspiration. So we count the ribs. So if the X-ray has at least 6 ribs on the chest X-ray, this is a good inspiration. So we can count. So this X-ray at least has at least 8 ribs. So we know this is a good inspiration X-ray. And the next one is projection. So there's 2 projection. One is PA, one is AP. So this X-ray is PA view because you see the 2 clavicles is outside the lung view. Okay, and then the next one is exposure. So the exposure, you can see the thoracic vertebrae faintly visible behind the heart. Okay, and then we go to the next point is basically to assess ABCDE system. So the first one is the airway. So for the airway, we check for the trachea. So the trachea has to be center. So if the trachea is
So can you
deviated,
tell me the parts first, doctor? Because I want to
okay,
know the
sorry.
parts first so I will
Okay,
understand what you are saying.
all right, thank you
What
for
is this?
reminding
What
me.
is this?
This is a normal X-ray. So normal X-ray has to have 4 borders. So you can see up here, you can see the trachea on top of the image. And on the side, you can see the clavicle and the shoulders. And at the bottom, you can see the abdomen and also the diaphragm. So you have to see the 4 borders first. And then we go one by one from top. We have the trachea, which is supposed to be center. Okay, you can see the spinous process in the middle of trachea, meaning the trachea is center. And then you can see the spinous process in the middle. Okay, and then again we have the clavicle on both sides of the trachea, which has same distance. And then we go down. We have the carina. Carina is the division of the trachea. And then we go down a bit. So we have the right atrium on the right side of the chest and the left ventricle on the left side of the mediastinum. Okay. On the side of mediastinum, you can see there's a pulmonary arteries. On the right is the right pulmonary artery, and the left you have the left pulmonary artery. And then we go down a bit. So as we go down, we have the diaphragm on both sides, right and left. So between the heart and the diaphragm, you have the cardiac border just on both sides, right atrium and also on the left ventricle. And as we go along the diaphragm on the side, we have both the claustrophrenic angles, which is the angle between the diaphragm and the the ribs, the last rib on the X-ray. So this is a normal X-ray basically. And then next we go to the, so this is X-ray. And then next we go to the breathing. For the breathing, we check the lung
For
fills.
the airway first, doctor. So you
Oh,
said,
sorry.
okay.
Yeah. So from this X-ray, you know the trachea center because
How to know regarding the airway, is it normal or any danger? What is the normal? What is the danger here
Okay,
in airway?
so in normal X-ray, you should see the trachea center, whereby all the spinous process is in the middle of the trachea. Okay, but in the and then the lung borders also is not pushed to any side. So you know the trachea is center, and also the mediastinum is not pushed to any side. Again, the trachea is center. So
So
as
the
you can see in
trachea
the
central,
Mhm.
the deviation, the carina visible.
Okay, right.
So
So
3
to know the
points.
center, okay, for the trachea to be center, it has to have 3 points. One is trachea center, and there's no deviation of the apex, and then the carina also visible.
Okay,
Okay.
so how to know there is danger?
Okay, so for danger, you can, for example, in tension pneumothorax, you can see the mediastinum is pushed or trachea is pushed either to any side, basically.
So the trachea is
And
deviated to the other side. It could be tension pneumothorax or massive hemothorax or any
yes, okay,
tumor or large
yes,
effusion. Okay.
yes.
Regarding the breathing,
So the breathing, basically, we're checking for the symmetry of both lungs, okay? And the size, you can see the size is has similar size. And then the lung marking should go from the center to all the way to the peripheries on both sides as well. And then you check, is there any abnormalities on the lung fields, like consolidation or any opacity? So in this X-ray, you don't see any obvious any opacity. And then you check any blunting of the both costophonic angles to check for any pleural effusion. And then lastly, we check for any loss of the lung markings, which could suggest of pneumothorax. So here we can see all the lung markings goes all the way to the peripheries. Okay. So the common finding in, okay, that's okay. And the next one is a cardiac silhouette. So basically for the cardiac silhouette, we are checking the heart size. So the normal heart size should be less than 50% of the both diaphragm diameter width. So if you put a imaginary line from the end of each diaphragm, so, and then you measure also the width of the heart. The heart width should be less than the diaphragm width. Okay, so that means that's a normal cardiac size. And then also you have to check all the borders and contours of the heart. You should see all the upper border, right and left, and the base as well. And then we also check for the aortic knob on the left upper border of the heart. Okay. What else? So if you see any, okay, so next one is the diaphragm. So the right diaphragm, in normal X-ray, the right diaphragm should be higher than the left because of the liver, presence of the liver. So if you see the right diaphragm is less or almost the same, it could be an abnormal X-ray. And then the next one, we check whether there's any air under the right diaphragm that could be suggestive of any pneumoperitoneum. What else? And then also check for any blunting of the diaphragm that could suggest a pleural effusion. Okay. So next one is the everything else. So for everything else, we check bones, soft tissue, devices, or any tubes. So for the bones, again, you can start from the middle. You can check for the thoracic vertebrae. You can see any obvious fractures from the thoracic vertebrae, which visibly, faintly visible behind the heart. We also can check the both clavicles and then the ribs, any rib fractures. And then also from here, you can see the shoulder X-ray, shoulder bones. Next one is you can check again for the in this X-ray, you want to check for any abnormality in the lung field. So here you can see the loss of the lung markings on the right lung. You can see the visible blue pleural line, and the lung is retracted towards middle. So this is a very large pneumothorax. And in this X-ray, you can see there's increased vascular congestion. The heart also enlarged. You can see the bilateral perihilar opacity, and there's also blunting of the costophonic angle, which suggests this is a pulmonary edema. Okay. So the causes of, okay. And next, this is pneumonia. This is, you can see there's an obvious opacity on the right lower zone of the right lung, which suggests of possible pneumonia in this X-ray. Okay.
Okay,
Other
thank you,
things.
doctor. Thank you.
Okay, thank you.
Okay. You are doing well, but you should be concise, okay? So
Okay.
again, if you find the actor is holding one X-ray, take your time, no problem. If you find the actor has like 5 X-rays, so be concise, okay?
Mm,
So
okay.
mention the normal and the abnormal to save time, okay? So for example, I want you to be fast with pausing also. For example,
Mm,
good morning, I'm Dr. Blah blah blah. Idris, may I know your name and level? Pause. Nice to meet you. Then I believe you have something to discuss with me regarding blah blah blah. Then pause. Once you go for, I will set learning objectives. I will teach you today patient and film details. It means accuracy. Then assess image quality. The mnemonic is RIPE, RIPE. Assess ABCDE system. I mean airway, breathing, cardiac silhouette, D for diaphragm, E for everything else, and check additional views. Is that okay? Yes. Then patient and film details, mention them quickly. So you can say accuracy, it means you should find name, age, ID, date and time, check type of X-ray, and the view. Is it AB or BA or lateral? If anything missed, it means not accurate. Easy, done, quickly like that. Then assess image quality. Right, R for rotation.
Rotation.
Okay. Then you can say check the clavicles equidistance from spinous process. Done. No need to explain much. No need to be dedicated. Then I for inspiration, at least 6 anterior ribs visible. Done. B projection, BA versus AB. So if you find the clavicle above the chest, it means BA. Okay. Exposure. So thoracic vertebra should be faintly visible behind the. Done. No need to go deep in each point. Clear? No need to
Okay.
explain more. I don't care the actor will understand or not. Clear? So the next point, airway. In airway, try to be fast so you can check the trachea if central, the deviation, the carina is visible. Done. Easy. No need to explain each point. So you can say if the trachea is deviated, it could be tension pneumothorax or massive hemothorax if trauma, or in medical disease could be tumor or large effusion. Done. Breathing. You can say check the lung fields, symmetry, lung markings, bronchovascular markings, any opacity, could be consolidation, and check any costophrenic angle blunting, it could be pleural effusion, check the bronchovascular marking if absent, it could be pneumothorax and the visible visceral line. Done. We finished. Then C, circulation. Check the heart and aorta. Check the heart size and cardiomediastinal contour. So mention the cardiothoracic ratio should be less than 50% of on BFM. Okay. So check the size of the heart and intrathoracic width. Okay. So check the mediastinum. If wide, it means aortic rupture or injury. Done. Then diaphragm. Try to be concise also. The right diaphragm should be above the left diaphragm. If you find any blunt of any angle, it means effusion. If you find any air under the diaphragm, means perforation. Done. Then everything else, check the bones of any fracture, like ribs or vertebra or spinous process. Check the soft tissue, okay, for any subcutaneous emphysema. Check devices, any device connect, like ET tube, NG tube, ICD.
Okay.
Check the also,
Yeah.
okay, done. Then additional views like what? Lateral view, BA view, or you can do another CT scan. Easy? Okay.
Okay.
I will give you 9 out of 10, but you are taking much time. Okay.
Okay.
You finished like 8 minutes or more. Okay. Thank you, doctor.
Okay. Thank you.
So if they give you 5 X-rays, then comment and management. So you can say the findings, diagnosis, intervention. Easy? No peripheral lung marking, visible pleural line, lung edge retracted, could be pneumothorax right side. This patient needs a chest drain. Done. Then the next one, I can see bilateral prehilar opacities, vascular congestion, pleural effusion, cardiomegaly. This could be pulmonary edema, it could be cardiogenic or non-cardiogenic. This patient needs Lasix, oxygen Lasix. Easy? Done.
Yeah.
And call the specialty, respiratory specialist. Here you will call cardiothoracic surgeon. Here you will call respiratory specialist. Here pneumonia, you will call respiratory specialist
Antibiotic.
if the score is a curve score more than 6, more than 3. Clear? Okay, so I can see consolidation, this opacity part, and it could be pneumonia. Done. Easy?
Yeah.
Okay, well done. So atelectasis, also take idea. When you are listening to the recordings, guys, I want you to pause the recordings and read all the slide. So read the normal, the abnormal. For example, here you will check the feature, you will check the causes, but you don't need to mention everything in the station, okay?
Okay.
Okay, next one. Rosamond?
Yes, sir.
Okay. Next one, Salter Harris fracture. I will give you idea, okay?
Yes, thank you.
So this one for baby or pediatric less than 18 years
Mhm.
because the epiphysis not united. So you have grade blah 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 blah. So 1, 2, 3, 4, 5. Okay. So here you will follow the same approach, introduction, and then learn objectives, patient and film details, that means accuracy, assess ABCS.
Yeah.
Any bone, you will
Mhm.
follow ABCS. Clear?
Yeah.
If you want to follow ABCDE also, no problem. If you want to
Yeah.
follow ABCDE, no problem. But this one, ABCDS, ABCS, S here, soft tissue. If you will follow ABCDE, E, it means soft tissue also, right?
Yes.
Okay. So A for alignment,
Yeah.
B for bones, C for cartilage, gross plate, and S for soft tissue, then check additional views. Okay. So A, alignment. What does it mean, alignment? Bone alignment.
Yeah.
Okay. It means the midline of the lower bone, same midline of the upper bone. Clear?
Yes, clear.
So bone alignment, joint congruity. Okay. So what does it mean, congruity? The widening here, same widening here, same widening here. Easy.
Okay, easy.
Joint congruity. Angulation displacement, any angulation or any displacement. Then the bones. Check cortical disruption. So you have cortex here, cortex here, cortex here, cortex here. So check cortical disruption.
Yeah.
If any disruption, it means a fracture. Check the metaphysis, then the epiphysis, then the physial widening. Okay. Physial widening, it means in the center.
Yeah.
So check the metaphysis and the physial widening.
Right. Yeah.
Metaphysis is down, epiphysis is up, and the physial widening in between. Then C cartilage gross plate. Okay. So symmetry of phases, widening, irregularity. So normal should be symmetric.
Symmetric.
Any widening, abnormality. Any irregularity, abnormality. Easy.
Easy.
Okay. Then soft tissue, check for any swelling. Any swelling, it means maybe fracture. Any joint effusion may be fracture. Any fat butt sign may be fracture. Okay.
Yeah.
So soft tissue swelling, joint effusion, fat butt sign. Easy.
Easy.
Okay. Then we will go for the types. So once you talk about the ABCS approach, you will jump to the Salter-Harris classification. So normal, you should find the metaphysis, then physis, gross plate, okay? Then
Yeah.
the epiphysis.
Okay.
No disruption, it means normal.
Yeah.
Type 1, it means S.
Mm-hmm.
So S start from type 1. What does it mean S? The fracture is straight across the gross plate. Easy?
Straight, yeah. Across cross plate, yeah.
Gross
Easy.
plate or physis.
Mhm.
Gross plate, it means the physis. So if the fracture across the S straight across the
Face
physis or gross plate, then A type 2, A
up.
above. So Salter, A above. It means in the epiphysis because epiphysis above, right?
Mm-hmm.
And metaphysis down. Okay. So if the fracture above, it
Mm-hmm.
means in above the metaphysis,
Mm-hmm.
it means what? Type 2.
Type 2.
If L means lower.
Lower.
So if the fracture lower
Mm-hmm.
epiphysis, okay. So it means type 3.
Type 3.
If the fracture through both epiphysis and metaphysis,
Type
it
4.
means type 4. If the fracture crush in the gross plate itself,
Mm-hmm.
So here straight but across
Across.
the physis. Here crush of the gross plate itself.
Yes.
It means type 5. Easy?
Easy.
Okay. Once you finish the explanation of each type, you will
Mm-hmm.
talk about prognosis. So
Mm.
type 1 and type 2,
Good program.
excellent prognosis. Type 3 and type 4, fair
It's
to good, may need surgery. And the type 5, poor prognosis, high risk for gross arrest. Clear?
yeah.
Okay. Then you will jump to common X-ray for Salter Harris areas. So common in distal radius in
Yeah.
the wrist, common in distal tibia in the ankle. So upper limb, wrist, lower limb, ankle. So wrist and ankle. Easy.
Easy.
And the digits. What does it mean, digits?
Fingers
Finger
and
phalanx
yeah.
or also the toes.
So
So wrist and digits, ankle and digits. Easy.
ankle. Yeah.
So in ankle, distal fibula,
Mm-hmm.
distal femur. Okay. So most common physical injury at wrist, common site for ankle injury, gross plate at the base of phalanges,
Mm-hmm.
common site of lateral ankle injury, important site for knee injury. So what does it mean? No need to explain in detail, but I'm explaining to you now. So any
Yeah.
patient, pediatric, he has pain in the wrist, you can
Uh,
expect a distal radius fracture.
I-
In the ankle, you can expect distal tibia fracture. In the fingers, you can expect phalanges fracture. Clear?
Clear.
Like that. Anyway, once you finish, maybe they will show you any problem, any X-ray. So if you find many X-rays, like 3, 4, 5, then try to be simple, concise, okay? So what is the problem, guys, here?
Slip of the distal is wrist. It's type 1.
Number
Number
one,
type 1.
mention the fracture where, in which bone?
It's a radial.
Which bone, guys?
Ulna.
It's a
Ulna.
ulnar radial. Wrist. Or is it thumb? If it is thumb is radius, isn't it?
Radius.
Radius, thumb is radius.
We said here distal what?
Distal radius. Oh, distal. Yes.
Common, right?
Yeah.
So common distal radius, distal tibia,
Mm.
finger phalanx, and distal fibula, distal femur. Okay?
Mm.
So this distal radius. So is it type 1, 2, 3, 4, 5?
This is type 1 slipped.
Yes, type 1, because the gross plate is intact.
Yeah.
So type 1. Okay. And what is this? Which
Um,
finger first?
It's which is it's middle finger. Is it middle finger? Yeah.
Ring finger, ring
Ring
finger.
finger, ring finger, yeah.
And this distal, middle, proximal, right?
Yeah, proximal.
Phalanx. Okay. So this which type of fracture?
This also slipped. Is slipped. It's not crushed. It's slipped. Slipped.
Above
So above. Yeah.
the fracture above, right?
Yes.
So above, what does it mean? Type
Above is type 2.
type
Type
2.
2.
So you can say the fracture site first. You can say I can see fracture in the ring finger,
Ring
in the
finger.
proximal phalanx. It could be type
Type
2 because above the gross plate. This is the gross plate. Can you see?
Yeah, above the
And the fracture here. Okay. Huh?
ring finger. This
Fracture where? The site first.
this ankle tibia.
Tibia.
Distal
This is
tibia.
distal tibia and is it through? So it's
No, this down.
Three.
only down. Okay.
So
Yeah, down is 3.
lower.
Lower,
It
lower,
means type 3. Salter. SAL. L.
L,
Lower. So type 3. S1. A2. L3. Clear?
yes.
You can say distal fracture of distal
Okay.
tibia.
Distal
Salter
tibia
Harris type 3.
type 3.
Why Salter? Because not united yet. Clear?
Yeah.
And the fibula also not united. If the patient has pain in the medial side and no pain in the lateral side, it means this is not fracture, this is not fracture. Easy?
Easy.
Okay. If the patient has pain here, pain here, pain here, so this is fracture and this is fracture. Did you get my point?
Yes. Yeah.
Clear, guys, this point?
Yes, sir.
If the
Yes, sir.
patient
Yes,
has
sir.
pain everywhere, so pain
Yes.
lateral, fibula is lateral. If the patient has pain in the lateral, pain in the center, pain in the medial. Once you touch here, pain, 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 pain. So this is could be fracture, could be fracture, could be fracture.
Mm.
If this one fracture, is it type 1 or type 2 or 3 or 4?
Type 1.
Type
Type
1.
1. And this type 1 and this type 3.
Type 3.
Clear, guys?
Clear.
Yes, sir.
But if he has been here only,
The only type 3.
I wish it's clear.
Yes.
Okay. What about this one?
This is true, so it is type
What is the
4.
side first?
What the four?
Is the index finger is
This foot.
middle flank.
Foot.
Metatarsal. Phalangeal.
Yeah, foot. Then it's first
MTP.
first proximal not
Big
phalange,
toe.
it's called the big
Big
toe.
toe.
Yeah.
So the first digit, it means the big toe.
Big
So
toe.
what is the fracture here? Above or below or gets raw?
This is true. So three.
True.
So classification?
It's a type
So the four.
Salter Harris type 4.
Type 4.
Okay, so above and below and in the middle also. So this type 4. Easy, guys, how to catch the problem?
Easy.
Okay, so also you can talk about ossification. So ossification, for example, in the elbow, if you still have time, you can talk about Kirito. Okay, so how to know this is fracture or Salter Harris fracture or ossification centers. So you will talk about 1 year, 3 years, 5 years, 7 years, 9 or 11. Okay. So it could be fracture type 1 or it could be not united yet. Easy?
Easy.
Okay. You have 30 seconds and 6 minutes.
Okay. Good morning. I'm Dr. Rosimon, one of the ED Reg. May I know your name and level, please? Nice to meet you. I believe that you have something to discuss about a pediatric X-ray, how it's called Salter Harris fracture. How much do you know about that? Do you want to know anything specific? Today, I will set learning objective for us. I will teach you first accuracy of the X-ray. It means that we need to confirm patient's name, age, ID, date, and time, and type of X-ray, whether it's AP, lateral, or Mortis view. And then we need to do say a systemic assessment and assessment of ABCS, which is we need to check the alignment and the bones, cartilage, and growth plate for the children, and soft tissues. And then we will check the additional views. And did you understand? So alignment, when we do the alignment, we need to see for example, this is a knee X-ray, the femur and tibia in the same line of alignment. There is no angulation or rotation. Okay, and joint congruity is means the whitening of the joint. We can see the whitening line of the joint, which is normal, and then we can see the bones. So bones, we need to check the cortical disruption, metaphysis, epiphysis, and physis. Okay, are you with me? Physis means the growth plate of the children, and they get uh, okay. Then we see the cartilage or growth plate, which is symmetry of the physis. Is there any widening or irregularity? If there is an irregularity, that's an abnormal. Okay, and there is soft tissue. Is there any swelling, any effusion, any fat pad? When you see the fat pad, that could be a subtle fracture. Then we can discuss about the Salter-Harris fracture. Salter-Harris fracture is we start with the normal one. Normal patient has got growth plate, physis, metaphysis, and epiphysis. Okay, and Salter is type 1. It means slip or straight across. If there is a fracture, if you can see the red mark, if the fracture is straight, that or the gap is above the physis, it's called the type 1 fracture, straight across or slip. And type 2 is above the physis, is called type 1 fracture. And type 2 is below the physis, is lower, is type 3 fracture. And type 4, we can see the through epiphysis, metaphysis, and physis. And type 5, which is crushed fracture. Type 1 and type 2 is most common and a good prognosis. And but type 3 and 4 might need surgery. And type 5 is a problem. It can affect patients' growth and development of the limbs. Okay, are you with me? The common sites of this type of fracture, it could be elbow, knee. Most common is the wrist, and there could be in ankle, the digits of the fingers and the toes. Also, there is a lateral ankle injury, common lateral ankle injury. Important site also in the knee, at the lower end of the femur. Okay, are you with me? Um, so,
You said distal, you said wrist. What do you mean by wrist? Which bone?
wrist is there could be a radius and ulnar, distal end of
Distal
the
radius.
distal radius. Yeah,
And you said in ankle, which bone?
ankle is a distal tibia.
And you said
And
in what
fingers and
else?
phalanxes.
Okay.
Okay, and then distal fibula is in the ankle, and distal femur is the knee.
Okay.
Yeah.
So what
And
about this X-ray, doctor?
so here we can see the X-ray. This you can see the thumb. So this is the radius.
This X-ray is adequate or inadequate?
This extra, we can see it's a
You can see the four
adequate.
borders.
Yeah,
You can see the four borders.
for yes, we can see
What
here.
is this X-ray? Is it wrist or hand or elbow?
This is the wrist
Wrist,
lateral
wrist,
lateral view of
wrist,
the
wrist.
yeah,
If you find all the wrist clear, it means wrist.
wrist
If you find the hand not clear, it's not hand. Easy.
easy. Okay,
Do you find the elbow?
no,
So this is wrist X-ray. Clear?
clear. Yeah,
So you can see the four borders. I mean, you can see above the wrist. What is above the wrist? Digits.
digits. Yeah,
Yes. What is below the wrist? The radius and ulna.
radius and ulna. Yeah,
So you can see up and you can see down. You can see the soft tissues.
yes,
Yes. So adequate, right?
it's an adequate extra. Yes,
Is this one accurate or not accurate?
not accurate because the patient's name, date, and
Information not there.
letters are not there. Yeah.
Okay. And alignment. Any problem in alignment?
Um, yes, but there
Yes.
is a fracture.
Yes.
Yeah,
Yes.
yes,
Okay. So in this X-ray, normal alignment in this view.
yeah.
This border, same this border, this border, same this border. But here, the same borders
No,
deviated, right?
It deviated, yeah.
So malalignment, right?
Yes.
It means the displacement.
Displacement here.
This
Yeah.
how to comment on the X-ray.
Okay.
You te you touch the normal and the abnormal. Then once you see abnormal, you can comment on the abnormal one. Clear? You said here alignment, right?
Yes.
You said you should see bone alignment,
Yeah.
joint congruity, angulation displacement. Then here you can see here in
The
the
alignment is displaced. Yeah.
yes malalignment and the displacement, and regarding congruity, no congruity. Clear? Okay. So here slipped only, no angulation. Okay.
Yeah.
Okay. So what is the classification of fracture?
This is a type 1.
Type
Slip.
1.
Yeah.
Okay. So you can say
This good prognosis. Yeah. This is a type
straight
1.
straight across the phases.
Yeah.
Okay. And this
Um, this is there is is above, so it's type 2.
so what is this X-ray?
It's X-ray of the ring finger of the
So X-ray
proximal
of wrist, is it
this
wrist or elbow
thigh.
or wait,
X-ray of
please,
thigh.
wait, please, be calm. So is it X-ray of elbow or wrist or hand or ring finger?
It's ring finger.
It means the one who did the X-ray, he targets the ring finger.
Yes.
It means he examined the wrist normal, he examined all fingers normal except the ring finger. That's why he did X-ray for the ring finger only. Did you get my point?
Yes, sir. Yes.
So this X-ray for ring finger, easy. Why
Easy.
ring finger? Because you can see above and down and right and left. Easy.
Easy.
Okay, so is it accurate?
Not accurate.
Is it
Adequate.
adequate?
Yes.
Adequate for the ring finger only.
Only ring finger only. Yeah.
Okay. And any problem in alignment?
Yes, there is it's not alignment, it's disrupted. So it's
So
yeah,
malalignment and
malaligned.
also displaced and angulated.
Yes.
There is angulation, right?
Relation, yes.
Okay. And what is the type of fracture?
This is above, so it's type 3.
Okay. And here, what is
Uh,
the
this
X-ray here? What is
below,
the site?
yeah, this is below. So it is
Ankle X-ray. You should mention the
also
X-ray first.
this is an ankle X-ray of showing the fracture of the
So is it
lower
left or right side?
this is right lower end of the
The
tibia.
fibula is lateral
Lateral, yeah.
and the tibia is medial. So this is left or right?
Tibia is medial and fibula is lateral. Then it will be
Left.
left, yeah.
Okay, so you can say this is left ankle X-ray.
Left
Before
ankle.
before checking the problem, you should say this is left ankle X-ray. Easy?
Easy, yeah.
Accurate or inaccurate?
Not accurate.
Not accurate, no information. Adequate or inadequate?
Adequate.
Adequate because you can see all the ankle.
Or
I don't care about the foot.
mhm.
I can see the ankle above the tibia and the fibula and below the foot and here the soft tissue. So everything is clear now for the ankle. Easy. So this one is adequate.
Adequate, yeah.
Okay, regarding alignment, any problem in alignment?
Alignment is fine, no problem.
Fine. So
Yeah.
the alignment for the fibula, if you put midline here, same. If you put midline here, same, right?
Yes, same.
So normal alignment. And regarding the cortical disruption, any cortical disruption? Yes.
Yes,
So you can see vertical line here. It means a cortical disruption. Clear?
yeah.
Any displacement?
Not
No.
not really, yeah.
The fracture in place. So
In
no displacement. Any angulation?
no angulation.
So only fracture.
Yes.
The
Yes.
fracture below the phases, it means class
Type 3.
type 3. This how to comment on the X-ray. Easy.
Easy. Yeah.
Because it will help you. This one needs back slab and refer to fracture clinic, or you will refer to orthopedic for
Oh,
ORIF.
yeah.
You have only two possibilities. You refer to clinic or you refer for surgery. Easy.
Easy.
Outside the hospital, it means you should do back slab. Don't refer without back slab. So you will do you will do back slab
That's
and then refer to fracture clinic.
yeah.
Okay? If angulated or displaced or malalignment, like this one, can you discharge this one?
No.
No. Okay. This one needs ORIF. Can you discharge this one?
No.
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 So any malalignment, any angulation, any instability, any neurovascular injury, I
Yeah.
mean the patient has problem in sensation, he cannot move his finger, okay?
Yeah.
Or open fracture, you can see the bone,
Yeah.
clear? So ORIF, easy?
Easy.
Okay. So comment on this one. I want you to comment on all point. I will not talk.
Okay, yeah. This is X-ray of index finger of a child, and it's showing that there is a fracture in the proximal. Oh no, no, this is a X-ray of a foot of the great toe, and showing this is adequate X-ray. This is not accurate, but it's an adequate X-ray, and the alignment is fine. But there is through Salter Harris type 4 fracture of the great toe, proximal great toe, and these patient need to be referred to orthopedics. They might need surgery.
Okay, so this right or left?
This is
Right foot.
right foot. Yes.
Okay, this the one who did X-ray, he targets the big toe only.
Yes.
It means he examined the patient. He has no problem in the other toes. He has no pain, but he has tenderness when you touch the proximal phalanx. That's why he target the big toe. So this adequate for the big toe only, not adequate for the foot.
But not adequate for foot, only big toe. Yeah.
Alignment, yes, there is alignment in the big toe, in the proximal and the distal phalanx. Okay, but there is disruption in the
um, in the joint proximal metacarpal
metaphysis,
metacarpal
physis, and the
metacarpal
epiphysis.
epiphysis.
Metaphysis, physis, epiphysis. So three points. Metaphysis, physis, epiphysis. Okay?
Epiphysis, yeah.
Okay. But the midline same.
Mm-hmm.
Clear?
Midline same, yes.
So a Vulcan fracture here. Okay?
Yes.
So here you can say the alignment is normal in the big toe. Here alignment is normal. So if midline from up to down, normal. Midline above, down, down, normal. Clear? But
Clear.
here malalignment, easy.
Easy.
If you will draw midline here, it will be away from this part. Clear?
Yes.
So
Malalignment.
here malalignment.
Yes.
Okay. I wish it's clear.
Thank you. Thank you.
Okay. So um
Okay.
okay. So here the management depends on what type and displacement.
Displacement, yeah.
So if type 1 or 2, maybe back slab, if no displacement. If
Mhm.
type 3 or 4 or 5, so surgery
Yes.
with or without displacement, okay?
Yes. Okay.
So what you will give the patient analgesia,
And
embolization, whatever is splint or cast,
mhm.
neurovascular assessment, then orthopedic
Orthopedic
referral, early referral to orthopedic if he has red flags. Red flags like what? Displacement, any
displacement.
significant
Neu-
displacement,
Neurovascular compromise.
Yes, and intra-articular. What does it mean, intra-articular? So fracture extend into the joint surface.
To the
Okay.
ground. And
Okay.
all.
Okay, thank you.
Thank you.
I will give you 8 out of 10. Next one, Sondos.
Yes, sir.
Okay. Here wrist fractures. It can come in the exam. So the most important, calls and dismiss. Clear?
Okay, sir.
So you will follow the same general approach. Introduction, patient and film details, it means accuracy. Assess ABCS, any bone problem. If you find, for example, in the exam, ankle, explain ankle x-ray. It will be the same approach, right?
Yes, sir.
So patient and film details, then assess ABCS system, alignment, bones, cartilage, and soft tissue. Check additional views. Clear?
Okay, sir.
So in alignment, you will assess radiocarpal alignment. Radio, it means midline in the radius, should transect the midline in the carpal bones. Easy?
Yes, sir.
So it's called radiocarpal alignment. Check carpal positioning, distal radial tilt, distal radial
Radiated.
tilt. Okay. So displacement or angulation. Regarding the bones, assess distal radial cortex. Okay, the borders. Ulnar styloid also. So you will check the radial cortex, the ulnar cortex, fracture lines, comminution, cortical disruption. In C, you will check the cartilage joints, assess joint congruity, interarticular extension, widening or step deformity, carpal joint alignment. Okay?
Okay, sir.
In soft tissue, you will assess for swelling, fat, planes, associated deformity, soft tissue injury signs, like that. Okay, what are the common wrist X-ray views? BA view, lateral view, oblique view,
Mm.
scaphoid view, if clinically indicated, if the patient has anything indicate scaphoid fracture. Clear?
Okay, sir.
Okay, so common wrist injuries, Colles fracture, Smith fracture, Barton fracture, scaphoid fracture. What else? Distal radial physial injury in children, peroneal dislocation, or ulnar styloid fracture. So these are the common fracture in the wrist. Okay?
Okay, sir.
The more common, okay, or the most common, you have extra-articular, it means horizontal fracture,
Mm.
or intra-articular, it means a vertical fracture. Clear?
Medical. Yes, sir.
Intra-articular, it's dangerous,
Mm.
needs a surgery. So you have dorsal angulation, it means the hand dorsal
Mm.
position. Or volar angulation, it means the hand in volar position. Clear?
Yes, sir.
So whatever calls or dorsal Barton, it means dorsal angulation. Clear?
Mm. Yes, sir.
If you have volar angulation, if horizontal, it means a Smith. If vertical, it means a volar Barton or reverse Barton. Clear?
Yes, sir.
So two in dorsal angulation, two in volar angulation, two in horizontal, two in vertical. I wish it's clear.
Yes.
Okay. You can follow ABCS approach. So alignment, we explained already. You will assess radiocarpal alignment. You will check the carpal positioning. So carpal alignment, this is vertical. Carpal positioning, this is horizontal. And the distal radial tilt, you will check horizontal line equal. Clear?
Yes, sir.
Bones, you will check the distal radius cortex, this area. You will check the ulna styloid, this area. Why I should mention these points? Because these are the common fracture sites. Fracture lines, the one in the midline, okay? And the comminution like this, okay? Cartilage joint, you will assess congruity. It means the curve is smooth. Intra-articular extension, okay? So any problem or disruption in the joint congruity, it means a fracture, okay? For example, you find this curve not matching this curve, above or down, it means something wrong. Easy?
Yes, sir.
Here, intra-articular extension. So if you find any radiolucent line or disrupted line in the cortex, it means intra-articular. Okay. So you will comment on Coles fracture. Maybe he will show you Coles fracture X-ray. Maybe he will show you Smith fracture X-ray. Easy.
Yes, sir.
So if he show you this X-ray, what is the diagnosis?
Sir, is it Smith?
Coles.
Collins.
Because like fork.
Okay. So the part is going dorsally. Okay.
Yes. Okay.
Mm.
This is horizontal or vertical?
Horizontal.
It means Coles fracture.
Okay.
Clear?
Yes.
If dorsal and intra-articular, I mean vertical, it means Barton.
Yes, sir.
Okay. This one, horizontal also. This is Smith fracture, okay?
Okay.
Smith fracture. So how to know this is dorsal or volar?
This
Volar.
is volar.
Volar. Because the hand is down.
Hmm.
Easy?
Yes, sir.
Here the hand is
Up.
up.
Yes.
Obvious.
Hmm.
So the radius here down. Easy?
Yes, sir.
I'm talking about the AB or BA view. Okay? So here the hand is down. It means the radius is up. It's obvious here. Okay? So this is misfracture. This is horizontal. And this one vertical. And the vertical here. This one even vertical and horizontal, but I will care about vertical. So what is the diagnosis? Barton.
Barton.
Is it volar Barton or reverse Barton? Or I mean
Uh,
dorsal Barton.
it's normal Barton.
So the hand is dorsal or volar?
Dorsal.
Volar. So can you imagine midline here in the radius?
Yes.
So the hand is in front of behind the midline?
Behind.
In front. Carpal bone here, right? This is the palm, right?
Yes.
And if you put midline here, this line, radio, radiopalmar or radiocarpal line, okay? So the hand volar or dorsal to this line?
Sir,
Volar,
I'm so
doctor.
bad
Volar,
at it.
volar,
Yeah,
volar.
volar.
The palm here
Hmm.
and the
Yeah.
line here, the line behind the hand. So the hand
That's
is
true.
volar,
Volar. Yes.
anterior, easy.
Yes.
So you will draw line. This line is called radio palmar or radio carpal line here. Okay.
Hmm. Hmm.
Here also, if you will, put line like this, it will be in front of the hand, not behind. Okay.
Hmm.
Anyway, so initial ED management, same as we mentioned earlier. So analgesia, immobilization, back slap, neurovascular assessment, reduction if displaced, usually closed reduction, referral to orthopedic surgery if unstable, intra-articular, neurovascular compromise, and so on. Clear?
Yes, sir.
Okay. So regarding cause of fracture, you will talk about definition, how to diagnose. So distal radius fracture with dorsal displacement, dorsal angulation. The mechanism will be fall onto outstretched hand.
Mm.
The appearance will be dinner fork deformity.
Definitely.
Okay. The X-ray features on lateral X-ray, distal fragment displaced dorsal, distal fragment tilted dorsal.
Mm.
Always associated with which problem? Radial
Radial
shortening.
shortening.
Radial shortening because the fracture in the radius.
Mm.
Ulnar styloid fracture. Okay.
Mm.
And regarding Smith, so distal radius fracture with volar displacement, volar angulation. The mechanism fall onto flexed wrist. So this one outstretched hand, this one flexed wrist. Clear?
Yes.
So the nickname reverse causes fracture, and the lateral X-ray distal fragment displaced volar or palmarly, volar tilt, often more unstable than calls. Okay.
Mm.
In Smith fracture, you will do ORF in type 2, type 3,
Mm.
neurovascular bundle compromise, any displacement or angulation, or type 1 but failed closed reduction. Because type 1, no need for ORF.
Mm.
So you will say, or type 1, if failed what?
Close reduction.
Yes, back slab and closed reduction. So you should refer to one. I wish it's clear. So this is the only general approach, okay?
Yes, sir.
You have 30 seconds and 6 minutes.
Good morning. I'm Dr. Sundar, CD Registrar. May I know your name and level, please? Nice to meet you. I believe you have something to discuss with me regarding interpretation of Coley's and Smith fracture X-rays. Do you? How far do you know about it? Anything specific you want to learn? Today, we will set a learning objectives for us that will include patients, details, and film detail, assess ABCS system, and then we will check additional views. I will also give you a few websites and videos to help you learn more from it. Let's start with the patients and film details. So, patient details should include the name, age, ID, and the film detail should include the date and time and type of the view should be written over there. And about the next, how to assess the X-ray, how to read on it, we
If
will
any of
follow.
them missed, what does it mean, doctor?
So if any of this is missed, the X-ray is not accurate. Then we will talk about ABCS system. This is a approach to read an X-ray. First of all, alignment. A stand for alignment. We will in our wrist X-ray we will see alignment using radiocarpal alignment. That means a line that is drawing from radial to carpal should be in a one line. And then we will be seeing the carpal positioning, and also see the distal radial tilt. That means the both the border of the radial distally should be in a one line, and displacement or angulation of the distal radius. Then we will talk about the bones. Bones will discuss about the all the cortex of the distal radius, ulnar styloid process, and fractures line if we find any. We also will see comminution and the cortical disruption if we found any. Next, we will see cartilage or joint spaces. We will see the joint concordity, intra-articular extension of any fracture. We will see widening or step of deformity or carpal joint alignment. Are you with me till now? Okay, we will now proceed with soft tissues. In soft tissue, we will appreciate any fat plan, or any swelling, any associated deformity, or any injuries in a soft tissues. Then we will discuss about the common fractures that we can appreciate on wrist. In wrist, we can appreciate the Colles fracture, Smith fracture, Barton and scapupoid fractures, distal radial facial injuries in children, perilunate and ulnar styloid presses. Also, we can interpret the X-ray by having noticing these points that are common, and these are so there are common views which are important to see or appreciate any fractures, that are PA view, lateral view, oblique view, or scapupoid view. So these are the views that we can use to see different type of fractures in wrist joint. Um, Talking about each fracture specifically, if we see that there are four important fractures, two fractures are extra articularly that can be conservatively treated, and two are intra-articularly, which are more you can say severe type of fractures. So if we talk, then the extra-articular can be dorsally, or they can be volar position. In dorsal position, we have Colles fracture. If it is extra-articular, we call it Colles, and if it is intra-articular but dorsally displaced, we will call it Barton fracture. Similarly, if it is ventrally or volar angulation, we will say it's Smith fracture, and if it is intra-articular volar displacement, then we call it reverse Barton fracture. Then we if we talk about the consider just Colles fracture, the definition of Colles fracture is distal radial fracture with dorsal displacement and dorsal angulation of the fracture. And the most common mechanism of this fracture is fall on the outstretched hand. And the deformity which we can see is called as dinner fork deformity. Then if we will talk about the Smith fracture is usually when we see the patient fall on flex wrist, and usually they present with the fall on the flex wrist, and we can define it as volar displacement or volar angulation of the fracture. So this is called Smith fracture. This is also called reverse Colles fracture, and there are three types of Smith fractures: 1, 2, and 3. One can be reduced by a closed reduction, but 2 and 3 can then be followed by orthopedics, and we need to involve them. So if we talk about this view, this is a X-ray wrist X-ray AP and lateral view, and we can appreciate that this is a Colles fracture because our fracture line is going dorsally, and this is vertical fracture. It's not involving intra articular line.
Is it accurate?
Yes, it's accurate.
No
For
information. No information.
yeah, it's not accurate. Yes,
Is it adequate?
it is adequate for wrist joint only.
Yes. So you can say wrist X-ray is adequate. You can see the digits. You can see the distal.
Yeah.
You can see the proximal bones, and you can see the soft tissues. Okay. So this one, the you can see the carpal bones
Mhm.
above the
Radius.
radius bone. Okay. And the head of radius also above the radius distal bone. Okay.
Mhm.
What about alignment?
Aligned, sir. Well aligned.
So the BA view is normal alignment, but the lateral view malalignment, right?
Yes, sir.
Displaced angulation.
Yes, sir.
Okay. What about joint congruity? Any problem?
No, sir.
No. So the problem not in the carpal bones, not in the distal borders, right?
Yes, sir.
So the problem here in the distal radius only. Easy?
Yes, sir.
Okay. What is the problem here?
Sir, it's a intra-articular fracture. Uh,
No, vertical.
yeah,
Horizontal.
vertical.
Horizontal.
Yeah, yeah,
Associated with the styloid fracture also.
yes,
So the carpal bones down. Okay. So this means Smith fracture.
yes.
Okay. So what about alignment?
Sir, not
No
aligned.
alignment. No
No.
alignment. Okay. You can see angulation. Yes.
Yes.
Okay. Is it accurate?
No.
Not accurate. Adequate?
Uh, yes,
Yes. So
adequate.
you can see the soft tissues, both
Yes,
sides. You can
yes.
see the digits. You can see
Mm,
the radius and the ulna, right?
yes, sir.
So adequate rest. Okay.
Mm, mm.
Okay. But no malalignment and displaced angulated. What about joint congruity?
It's normal over here, but the radius styloid is,
Ulnar styloid.
yeah, sorry, ulnar styloid, yes.
Okay. So disruption here.
Disruption, yes.
There is no curve between the styloid and the carpal bones. Clear?
Yes, yes, sir.
The congruity here intact. It means normal widening here, normal widening here, like 5 mm. Clear?
Hmm.
It
Yes.
should be here also. We will go for
Hmm.
this one. Can you see the widening here? Normal, normal. Clear?
Yes, sir.
Also here accepted. But here the
Hmm.
styloid also fracture.
Yes,
This part, can you see the disruption here?
yes, sir.
Can you see the
Yes,
disruption? This
yes.
part should be here,
Should be there. Yes.
and the distance should be normal.
Hmm. Yes.
Okay. So what about this one? Congruity here disrupted
Yes, it's no,
because it's a
neither.
vertical.
Yes.
If horizontal, if horizontal, the congruity is
Mm,
still normal.
mm,
The space is still normal. Did you get my
mm.
point?
Yes, sir.
The curve is still normal. But here, because it's a vertical fracture, there is disruption here. What about the styloid process?
Displaced, disrupted.
So fracture here also. Clear?
Yes, sir.
Okay. So congruity, even here, the carpal bones are normal. Can you see the congruity here? The
Yes.
widening normal, normal, normal here. Okay.
Mm,
Here normal also. The space is, the curve is normal. Okay.
mm.
Like that. Okay. So what is the management?
So we will give analgesia immobilized by back slap. We will apply back slap and will also check neurovascular status before and applying back slap. And then we might need to reduce the portion of the fracture. And if not, then we can refer. The Smith one can be referred to orthopedic, but 2, 3 needs in if it's intra-articular unstable or there is any neurovascular compromise, then it needs surgery inpatient.
Okay, thank you, doctor.
Thank you.
Okay, I will give you 8 out of 10. Thank you. Okay, last station for today, elbow fracture X-ray. Who is happy to do this station? I will give idea. Who is happy to do this station?
I can do it if you give idea.
Can I do, sir?
Anyone did not practice today?
Atul.
At all, okay. So elbow fracture X-ray, you will follow the same general approach, okay? So I will set learner objectives for you. Today I will teach you patient and film details. I mean accuracy, then assess ABCS system, then check additional views. Then talk about each one. Regarding patient and the film details, confirm patient name, blah, 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 blah. You will mention all these points. Then assess ABC system. So you will talk about A alignment. Okay. So you will talk about radiocapitellar alignment, anterior humeral line. I'm sure all familiar with this
Yes, sir.
point. Joint congruent, B bones. So you will check distal humerus because we are talking about elbow. So focus on elbow now. So radial head, olecranon, cortical integrity, subtle fracture lines. Then see cartilage joints. So you'll assess joint alignment, physical injury, interarticular extension, soft tissue. You will check joint effusion, anterior fat pad, and posterior fat pad.
Yes, sir.
So radiocapitellar line, this line through the radial neck head should always intersect the capitellum on all views. So if you find the radial head dislocation, if abnormal. Anterior humeral line along anterior cortex of humerus should pass through the middle third of capitellum on lateral view. So if not, it means a supracondylar fracture if displaced.
Yes, sir.
Okay, clear, doctor?
Yes, sir.
Okay, so we will comment on fat bad signs. So especially in pediatric, if you find, I said especially, it means you can use in adult also. Yes, clear at all?
Yes, sir.
So regarding anterior fat bad sign, normally can be there, but if you find elevated up anterior fat bad sign, this is called the sail sign, this subtle fracture. If you find the posterior the same as this anterior, but in the posterior, clear?
Yes.
So posterior fat bad sign behind the humerus, not in front. So it will be here. Okay? So
Yes,
it means subtle fracture also. Clear?
sir.
Okay. So if you find the anterior, this is called the joint effusion. If you find the posterior, this is subtle or occult fracture. Okay, commonly tested elbow fractures. So check the mechanism. So fall on outstretched hand injury. The danger here of supracondylar fracture, brachial artery injury, medial nerve injury, compartment syndrome. Okay, so here regarding the features, being on pronation or supination, you will think about which fracture,
Radial head.
radial head fracture. So now we finished talking about what? We finished talking about
Sup
supracondylar fracture, right? Then we will go for radial head fracture. So how to catch this one? You will find on X-ray, yes, but before doing the X-ray, you should check the features, the signs. So when you ask the patient to do pronation, supination, he has pain. Pain where? In the radial head. Subtle cortical disruption, adults more common. Okay, so this pronation view and this is supination view. Okay, what is the diagnosis?
Olecranon fracture.
Yes. So if the actor gave you X-ray, you should diagnose. So posterior elbow pain, when you touch this area, he has pain, tenderness. Visible fracture lines through the olecranon, so obvious. This view or this view, obvious both sides.
Yes, sir.
Lateral condyle fracture also. Okay.
Yes.
So this one olecranon, this one lateral condyle fracture. So you can see lateral or medial. Okay. The radius is lateral or medial.
Lateral.
So this lateral condyle, this medial. Okay. So you can, but I said common. That's why I did not show you medial. Clear? So lateral condyle fracture can appear subtle, gross disturbance. This is a complication. So any fracture in general, if the actor asks you what is the complication, you can say maybe malunion, maybe non-union, or gross arrest. Clear?
Yes.
Okay. So you will check neurovascular assessment. So you will check the radial pulse because the problem in the elbow, it means your concern may be artery, brachial, or maybe uh, median or radial nerve. Clear? Or ulnar. Clear at all?
So,
So you will check distal to assess the elbow. Check neurovascular distal. So you will check distal, radial pulse, capillary fill time for 5 fingers. Okay. Then you will check median nerve sensation and the power, radial nerve sensation and the power, ulnar nerve sensation and the power. Okay.
yes.
Okay. So the management also same initial ED management, analgesia, immobilization, backslap, neurovascular assessment, reduction if displaced or um, angulation, usually closed reduction, refer to orthopedic if unstable intra-articular or neurovascular compromise. Clear?
Yes.
Okay, so I think your points in fractures focus on supracondylar, it means the distal humerus.
Yes.
Think about head of radius. Think
Yes.
about olecranon. Think
And
about
lateral condyle.
lateral condyle. Clear? What about additional views? So you have a BA view or AB view, lateral view, like that. Okay?
Yes.
You have 30 seconds and 6 minutes.
Yes. Yeah. Can I start?
You can start, please.
Good morning. I am Dr. Atul. May I know your name and grade, please? Thank you. I believe you have a here for X-ray elbow. May I know how far you know about X-ray elbow? Do you want any specific in X-ray elbow? Okay, I will set learning objective. Today I will teach you regarding the accuracy, regarding the adequacy, regarding the alignment, bones, cartilage, soft tissue. This will start from the patient and film detail, and I will assess from alignment to soft tissue and check additional view. And after this, I will give you some websites, RChem websites to learn more. And in the routine practice, I will show you the X-ray, whatever X-ray will come related to elbow. Is it okay for you? Thank you. So to start with, first, in any X-ray, we should confirm the patient name, age, and ID. We will check on which date and which time the X-ray was done. And we check whether the X-ray is elbow, which view, anterior posterior view or lateral view. We should confirm. So this comes in the accuracy of the this. Then we will go for adequacy. Adequacy means we have an elbow X-ray. We should see the humerus, complete distal hand of the humerus, and we will see the radius and ulna, all the proximal aspect to the mid aspect. And on the lateral side, both side, we will see the soft tissue. So that is includes adequacy. Coming to alignment of this, we have to assess lines. Lines we can assess from first is anterior humeral line. From the anterior cortex of the humerus, the line should go down with the middle third of the capitulum. It should intersect the middle third of the capitulum. So it is a normal alignment. Considering radiocapitular line from the mid part of the radius, we will draw the line upwards, perpendicular, and it should go in between from the middle of the capitulum. That is a radiocapitular line. Then we have to see the joint congruity, that it should be regular. There should not be widened space. These three terms complete the alignment of the elbow. Then coming to the bones, distally, we have a distal humerus, we have a radial head, we have a ulnar or olecranon process of ulnar. Then we need to check the cortex, continuity of the cortex. There should not be break in the continuity of cortex of all this bone. Coming to the joint, we should see any widening of the joint, and we will see for any physeal injury in case of child. And if any fracture or any etiology is there, then we need to check whether it is intra-articular extension is there or not. Coming to the soft tissue, we need to see the joint effusion. We need to see the fat signs. There are two fat signs. Normally, we can see anterior fat, just anterior to the distal aspect of the humerus, lower end, and it is seen in the lateral view only. And if the anterior fat pad is elongated, then it is an abnormal sign. Abnormal signs means it indicate joint effusion and indirect occurred supracondylar fracture of distal aspect of the humerus. Are you able to understand? Yes. So this is and if it will come to the posterior fat sign. If posterior fat sign is present, then it is always abnormal. Now coming to this X-ray, see.
So what is the problem if the patient has supracondylar fracture? What is the danger here?
Yeah, so supracondylar from the elbow, we are brachial artery is going and median nerve. So there could be injury to the brachial artery.
This early complication. What about the late complication?
Yes, there is a compartment syndrome.
Okay. So what are the classes of supracondylar fracture? I heard about something like Gartland classification, like xray classification.
Yes, if there is a occult fracture and there is no displacement, if only visualization of anterior and posterior fat sign, that is a type 1.
Okay, type 2.
And type 2 is there is a clear-cut fracture with, I am not sure about the display.
So disrupted anterior cortex, but intact posterior cortex.
Okay. And the third one is displaced supracondylar fracture, clear-cut visualized.
Okay.
And 1 and 2 may treated as a conservative, and for 3 we need to urgent consult orthopedics.
So class 1, we will do back slab and
Yes.
charge, and the class 2, class 3 refer to orthopedic for closed reduction.
Yes.
Okay. What other fractures we should think about in elbow?
In elbow, if the patient is adult, then adult usually has a radial head fractures with clinical presentation, tenderness over the radial head, and when they do pronation and supination, there is a clinical discomfort.
So what is the problem in this X-ray?
This is the fracture of the radial head.
Okay, which
Pronation
view?
view.
Is this pronation or supination?
This is a pronation view
And is
because,
this one?
yeah, this one is a supination view.
Okay. And what other fractures
Yeah, this
expected in elbow?
elbow in elbow, there may be on the, if the posterior tenderness is there and patient fall down on the elbow, so there may be obliqueron process like seen in this X-ray. And
Okay.
if there is on the tenderness on the lateral aspect, then it is a lateral condyle fracture.
Okay.
And this lateral condylar fracture and this we need.
So, what is the most important?
Okay, so with any fracture, we need to always assess for the peripheral pulse, which include radial pulse as well as capillary refill in the fingers. Along with the sensation, we need to see the sensation along the median nerve, radian nerve, and ulnar nerve over the hand. So neurovascular sensation, neurovascular should be intact. This is very important. Before the when we see the fracture, after application of back slab also we need to check this for confirmation. Do you have any?
Okay. So how to assess the median nerve?
So median nerve, you need to take sensation in the median nerve territory, and this includes the this lateral.
Okay, thank you, Atul. Thank you. Well done. Okay, thank you.
Thank you.
So how to assess the median nerve, guys? Sensation first.
Check sensation.
Sir, check sensation on the middle finger and also the motor function of thumb.
So the median nerve, you can check the thumb, right?
Yes,
The ulna, you can check the little finger.
middle finger. Yes.
And the radial, you can check the dorsum of middle finger. Okay.
Yes.
And regarding the power, you can ask the patient to put the thumb up
Mhm.
and ask him to make the thumb push against you. You will push the thumb down. He will push against you. Okay.
Yes.
The radial, you will push the
Fingers.
fingers down.
Yes.
And regarding the ulnar, you will ask him to splay his finger and you will push his fingers inside against the resistance. Okay. We will do this in examination later, inshallah. Okay. We will stop here, guys. I think we almost finished. So they can show you any X-ray. So this one normal or abnormal?
This one is normal.
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 Normal. Number
Right.
one,
Yes.
no fat but sign, right?
Yeah.
The color is same here, here, here. And the anterior humeral line transecting the capitellum, the radiocapitellar line transects the capitellum. The cortex posterior intact or not intact?
Intact.
Intact.
Any disruption?
No disruption.
The anterior cortex intact.
Intact.
So no fracture. Easy.
Is
If you find the fat butt sign or anterior humeral line or radiocapitellar line not transecting the capitellum, it means a class 1. If you find disrupted anterior cortex, class 2. If you find the disrupted anterior and the posterior cortex, class 3. Easy?
Yes, sir.
Okay. Here, any fat butt sign?
Anterior slight.
No, sir.
No. It should be obvious like this here.
Yeah.
What about anterior cortex, posterior cortex?
intact.
Intact. So
Yes.
white. So intact. Clear?
Yes, sir.
Okay. And the anterior humeral line transecting the capitellum? Yes.
Yes.
Radiocapitellar line transecting? Yes.
Yes.
So no fracture, right? What about
Right.
the olecranon? Any fracture?
No
No.
fracture.
No
And
cartilage.
the radial head? Any fracture?
No
No.
fracture.
So seems normal, right?
Yes.
Yes.
Is it accurate?
No,
No,
details are not there.
no
Mention
details.
only L, but no
Hmm.
information, so not accurate, right?
Yes.
Okay, and regarding adequate
Adequate, yes.
Adequate for elbow joint.
for your elbow, because you can see the humerus, you can see
Yes.
the ulna and radius, you can see
Hmm.
the soft tissues. It
Yes,
means
sir.
adequate, right?
Yes.
Alignment normal?
Yes.
Yes. Alignment, it means anterior humeral line, radiocapitellar line, easy?
Yes, sir.
Okay, and what about bones? Normal.
Hmm.
Yes.
Okay. And regarding the joint, what about joint congruity? The curve is normal,
Normal.
and the
Normal.
curve here normal.
Yes.
So it means normal, right?
Yes, sir.
Okay. And what about this X-ray?
Normal X-ray, but
Sir,
adequacy,
the joint. Yeah.
adequacy is not.
Adequate. Adequate. You can see the soft tissue here, soft tissue here, soft tissue here, and the humerus. You can see the ulnar radius. So the elbow joint adequate, right?
Yes, sir.
Alignment also
Normal.
normal. Okay.
Hmm.
Okay. Here,
Here, and posterior fat sign is there.
anterior
Anterior
and
fat
posterior
belt,
fat bites.
There,
Fat, yes,
fat back.
anterior obvious, posterior obvious, right?
yeah.
Yes, sir.
Type
And
1.
regarding the anterior humeral line transecting,
Hmm.
yes.
Yes.
And the radiocapitellar line transecting,
Yes.
Hmm. Yes.
yes. And what else? This pediatric or adult?
It's a pediatric.
Pediatric.
Pediatric, because
Yes.
the radial
It
head
Fine.
is.
here not united yet.
Hmm. Yes.
Of course, you should confirm with age.
Yes.
Okay. And this, what is the fracture here? What is the type of fracture?
Type 1 supracondylar fracture of humerus.
Yes,
Yes.
excellent. Any problem in olecranon?
Oligron ossific. No fracture.
Okay, so we have here ossification centers. We have ossification center for radial head. We have for lateral condyle, medial condyle. Okay, and the capitellum. You should be familiar with that. 1, 3, 5, 7, 9, 11. Clear?
Yes.
Okay.
So,
What is the problem here?
there is type 2 supracondylar fracture. There is disruption of the anterior cortex.
Cortex. So the posterior cortex is still intact,
Yes.
Yes.
but the anterior cortex is disrupted here.
Yeah.
So fracture of supracondylar fracture class
2.
2. The radial head, any fracture?
No
No.
ossification there.
The ossification not united.
Yeah.
The lateral condyle not united.
Yes.
The medial condyle not united, right?
Yes.
Yes.
But this fracture, you can see here also. Can you see?
Yes.
Disruption here, radiolucent line. Okay. What is the problem here?
Olecranon fracture of the ulna.
Olecranon fracture. Okay. What about the radial head?
Intact.
What about joint congruity?
Normal.
Normal. So the curve is normal, right? The curve here normal also.
Yes.
What about the problem here?
Radial head fracture.
Radial head.
Depressed, right?
Yes.
Yes.
This
What
joint
about
congruity.
the joint congruity affected here?
Yes.
Very
Yes.
wide, right?
Yes.
Yes.
But here normal, normal, normal. Okay. Okay, excellent, guys. I think this station we practiced already, but I try to remind you. So we did that before in previous recordings. Okay.
Yes.
Okay. Thank you, guys. We will stop here. Inshallah, tomorrow we will be joint examination. After tomorrow system examination, be ready for tomorrow, guys. Okay.
Inshallah.
Thank you, doctor.
Thank you,
Thank
sir.
you.
Thank you so much. This
Thank
was
you.
really informative. Thank you.
Thank you, guys. We are here to help you. Okay. Thank you. Bye bye.
Thank you.
Wow.